Shivangi, good evening.
Yes, doctor.
Yeah, we'll start at 7:30. Okay.
Yeah. We'll start exactly at 7:30.
Okay. மேடம் எப்படி இருக்கீங்க?
கேக்குதா சார்?
கேக்குதுங்க மேடம், கேக்குது. மேடம் நீங்க இதை எடுத்துடலாமே, நீங்க இயர்போன் எடுத்துட்டு டைரக்டாவே பேசலாம் நினைக்கிறேன்.
இருங்க சார், ஒரே நிமிஷம். என்னோட ஸ்பீக்கர் சரியா இல்லாதனால ரெண்டு சிஸ்டம்ல
நீங்க பேசுறது எனக்கு கேக்குது, நல்லா கேக்குது. இப்ப கேக்குதுங்களா
சார்? இப்ப கேக்குதா?
இப்ப நல்லா கேக்குது. நான் பேசுறது கேக்குதா?
கேக்குது சார், நோ ப்ராப்ளம்.
ஓகே. நீங்க பெடிகான் போலியா?
இல்ல சார், நாய்டா அப்பயே புக் பண்ணவே இல்லை. ஆனா கொடைக்கானல் புக் பண்ணிருக்கேன்.
ஓ சரி.
தமிழ்நாடு புக் பண்ணிருக்கேன். இது நீங்க போலையா சார்? போயிட்டு வந்துட்டீங்களே, நீங்க தானே ஒரு இதுல டாபிக்ல பேசுனீங்களே, நான் பார்த்தேன்.
போயிட்டு இங்க ஐசிடி ப்ரோக்ராம் வந்திருந்தேன், வந்துட்டு அப்படியே நேரா
இந்த மந்த் ஆக்சுவலா பிஜிஸே இல்ல சார். அதாவது பிஜிஸ் எல்லாம் தேர்ட் இயர்ஸ் வந்து எக்ஸாம் போயிட்டாங்க எங்களுக்கு தமிழ் கவர்மெண்ட் சர்வீஸ் சைட்ல.
சரி.
பிஜி அதனால செகண்ட் இயர்ஸ் தான் ஃபுல்லா வேலை பார்த்துக்கிட்டு இருக்காங்க. ஃபர்ஸ்ட் இயர்ஸ்க்கு ஒண்ணுமே தெரியாது. அதனால நாங்களே இந்த பீரியட்ல நீங்க வந்ததே பெரிய விஷயம் தான். இதை கண்டக்ட் பண்ணதே பெரிய விஷயம் தான்.
பரவாயில்ல மேடம், 200 பிஜிஸ் இருந்தாங்களே, நல்லா இருந்துச்சு.
ஓஹோ, ரெஜிஸ்டர் பண்ண. ஓகே.
பரவாயில்லைங்க, 200 பிஜிஸ்.
அப்ப போதும் சார், அவ்வளவுதான், ஓட்டிரும் சார். இவர்கிட்ட சார்கிட்ட பேசிட்டோம், ஜுல்ஃபிகர் சார்கிட்ட.
சரி மேடம்.
ஒரு ஒரு ஃபர்ஸ்ட் வந்து இந்த ப்ரோக்ராம் 1.5 hours முடிச்சிருவோம் சார். 7:30ல இருந்து 9 வரைக்கும். அதுக்கப்புறம் ஒரு half an hour வந்து சார் என்ன சொன்னாரு, அவர் 20 minutes கிட்ட கன்ஜஸ்டிவ் கார்டியாக் ஃபெயிலியர் பத்தி பேசுறேங்கிறார்.
ஓகே சரி மேடம். சரி, நீங்க அட்ஜஸ்ட் பண்ணிட்டேன். சரி,
அது நம்ம அவர்கிட்ட பேசிட்டோம். ஓகே
சரி
சார். குட் ஈவினிங் பாபு சார். குட் ஈவினிங் சார்.
அன்மியூட்டுங்க. டாக்டர் பாபு நல்லா இருக்கீங்களா?
நல்லா இருக்கும் சார். எப்படி இருக்கீங்க?
நான் பிஜி போடுமா, நீங்க ஜூனியர் ஆக்கில 1 இயர்ல.
ஆமா நீங்க தேர்ட் இயர், நான் ஃபர்ஸ்ட் இயர் பிஜி.
இருக்கு
2 யூனிட் எவ்வளவு நாள் பண்ணாம.
ஆமா, நம்ம நாளுக்கு பின்னால 20 வருஷம்.
நீங்க எப்படி இருக்கீங்க சார்? கோயம்புத்தூரா?
ஆமா.
எங்க இருக்கீங்களா சார்? இது சரவணன் சார் எப்படி இருக்காரு, உங்க க்ளோஸ் ஃப்ரெண்ட்?
நல்லா இருக்காரு.
சரி, ஓகே.
பரமக்குடியில் இருக்காரு. பரமக்குடியில் இருக்காரு.
அதான் சார்,
பரமக்குடி.
பரமக்குடி தெரியும். ஒரு 2 நாள் முன்னாடி பார்த்தேன், இப்ப ரீசெண்டா பார்க்கல.
சரிங்க.
ரிலேட்டிவ் பரமக்குடி தானே சார் இருக்குல்ல?
ஆமா, பரமக்குடியில் தான்
செட்டில் இல்ல சார்.
சார் ஜுல்ஃபிகர் சார், வெல்கம்
சார்.
ஆமா, வெல்கம் சார்.
குட் ஈவினிங் சார், ஜுல்ஃபிகர் சார். ஐ அம் டாக்டர் பாபு கந்தகுமார் சார்.
Yeah.
From Thuthukudi Medical College.
Thuthukudi Medical College. Yeah.
Yes, sir. Yes, sir. Yes, sir.
Thuthukudi.
Nice to meet you, sir.
I had come some 20 years back when my brother-in-law
20 years
was
back.
Park.
Sir, good evening, sir.
He was in
Sir, good evening.
Park.
20 years back.
That is, I saw all the salt.
Recently, நிறைய change Thuthukudi.
Very change வந்திருக்கு இல்லையா?
Development நிறைய இருக்கு.
Medical college வந்திருக்கு.
Yes, sir. Yes. I am native of Tirunelveli. So I am my house was situated in Tirunelveli. I am working at the Thuthukudi. That's all. Previously, I worked in Tirunelveli Medical College as associate professor. It is about 40 kilometers from Tirunelveli. Daily, I am traveling to Tirunelveli and attending work.
I have
Nice
other
to meet you, sir.
My brother, younger brother, did MD in Tanjavur.
Tanjavur Medical.
Dr. Babu, I think என்ன ஞாபகம் இருக்கு எனக்கு, நீங்க ஒன் ஆஃப் தி ஹார்ட் ஒர்க்கிங் பிஜி நினைக்கிறேன்.
யாரு?
Babu, Babuங்க. Very hard working, always running here and there, எல்லாம் போய் இன்வெஸ்டிகேஷன் கலெக்ட் பண்றதுல I think so hard work.
Monday unitல போறோம் சார். ICS Monday unit ரொம்ப hectic. Admissions வந்து more than 100 மேல போகும். Diarrhea வால 150 cases போகும். So we had a hectic time. We had very good training at ICS. Very good teachers at the time.
So when I was a final year PG, he is the first year.
Yes, sir. Yes.
Dr. Lakshmi.
Sir, good evening, sir. Can you hear me, sir?
Sir. Srinivasan, sir.
Srinivasan, sir, good evening.
Good evening.
Srinivasan, sir, good evening, sir.
Srinivasan sir, வந்தா களை கட்டுது அப்படியே.
நீங்க வரலையே. You didn't come to.
So I tell you, sir, one thing. If Doyen, DOYEN, na South India ile equal Srinivasan sir தான். அதுக்கப்புறம் எனக்கு தெரியல.
சொல்றாரு புரியலையே எனக்கு.
No, பொய்யல்ல. நிஜமா. You know me. I am a very truthful person.
I am not understanding what you are saying, I say. I understand what you are saying about cardiology and congenital heart diseases and rheumatic heart disease, but இப்ப சொன்னது எனக்கு புரியல. புரியாது. அது அங்கே அப்படியே இருக்கட்டும். Because self-realization, because when you get self-realization, then I think probably you will become, anybody can become little, more than what they are. So better not to have a self-realization. That is what Milton says. Thank you, Lakshmi Vellimurugan.
Sir, you had a very nice time in Noida and Pathen, sir. Nariya photos paatha. Good evening, sir. Can you hear me, sir?
I am a very good student, I can tell. I don't know whether I was a good student when I did MBBS MD. Now I am a very good student.
Okay, very good. Sir, Zulfikar sir, in fact, as a postgraduate, ungaloda notes தான் நான் படிச்சு rheumatic heart disease,
seriously,
heart disease, tetralogy of fellow. We had those small books which you had released, sir. We were reading only
small
that.
book, yes.
You had
Satish, rheumatologist pediatric Vellurla. அவர் வந்து என்னுடைய பிஜி காமிச்சிருக்காரு. அங்க வந்து ஜாயின் பண்ணால லக்ஷ்மி ஸ்ரீனிவாச ராகவன் சார் வந்து அந்த பிஜி எக்ஸாம் கோயிங் பிஜிக்கு எடுத்த மியூகோ பாலிசி நோட்ஸ் அப்படியே வச்சு காமிச்சிருக்காரு. ஆச்சரியமா இருந்தது.
We were all very ardent fans of both of you, sir. Srinivasan sir as a senior and Zulfikar sir for any cardiologist, sir. எந்த கார்டியாலஜினாலும் அந்த புக் தான் we used to go through. Tetralogy of Fallot, asymptomatic heart disease, rheumatic heart disease.
Zulfikar has always been a very important mentor in my development.
Dr. Babu
நீங்க இதுக்கு வரல IAP TNSC சார் Zulfikar நீங்க IAP TNSC வரலையே.
எங்க
வந்தீங்களா நோய்டா?
நோய்டா வந்தீங்க சார். 3 days one day I saw you in the front. I came searching for you. Ledda madam told me that you are in the front row. Then I came there. By the time I think you had left. We were sitting in the back. Ledda madam actually she spotted you and then she told me Srinivasan sir.
So I was not fortunate enough to meet you there and this thing. Yeah.
Then what happened was the next day I had some fever. So I was a little worried whether I was having another COVID or what, but it subsided, I think, one day.
Hi,
sir, Zulfikar sir, in the class, we are waiting. All students are like your.
Anytime.
Yeah.
Anytime, sir. Our Jennifer is there, right?
Yeah.
Jennifer is the one who is presenting.
Gopika is
Gopika
also there.
and Radhika.
Gopika and Radhika.
Yes, sir.
Is it a K or H? Radhika. Radhika. Dr. Radhika's name, is it a K or a H? Because in the print comes as H.
Good evening, sir.
Good evening.
Jennifer, can you switch on your video because somebody's photo is only coming.
Annamalai sir, vanakkam.
Very good.
Hello.
Okay, Jennifer. Sir, good evening. AV sir, good evening, sir.
Good evening.
Vanakkam, sir. Good evening.
Madam, உங்களுக்கு ரெண்டு டிவைஸ் இருக்கு லட்சுமி மேடம். You are having Lakshmi iPhone வந்திருக்கு மேடம்.
ஆமா சார். ஆனா எக்கோ ஆகல இல்ல சார்?
ஆகல.
Okay sir. ஆமா கரெக்ட் தான் சார். Okay, because என்னோட
So Srinivas sir, good evening sir. I am Dr. Babu Kandakumar.
Hello sir, good
Working
evening.
as an associate professor at Thuthukudi Medical College, sir.
Good evening sir, thank you.
Okay, sir. I did my MD pediatrics at ICH in 1996 to 99.
Okay, sir.
I did my research in Madurai Medical College between 93 to 95.
Okay.
And I worked under Dr. Kadhi Subramaniam from Pondicherry.
Okay.
He was my professor during the initial years, and he retired. And at present, I am working as associate professor at Thuthukudi Medical College.
It's a pleasure meeting you, sir.
Yes, sir. Thank you, sir. Very nice. Glad to meet you, sir.
Yeah. I am blessed today.
Yes, sir. Thank you, sir. Thank you.
Dr. Rajendran, sir. Good evening.
Annamalai sir, welcome.
Rajendran.
Dr. Madam, Lakshmi Madam, good evening.
நீங்க தலைவர் ராஜேந்திரன் சொல்ல வேண்டாம், தலைவர் சார்.
ஒண்ணும் வேண்டாம் சார். நான் எப்பயுமே தொண்டர் சார். தலைவர்னாவே கீழே கவுத்துருவான் சார். வேண்டாம் சார்.
சார் செகண்ட் இயர்ல third fourth program இது.
Sir, Dr. Ahmed sir, good evening.
மேடம் லட்சுமி மேடம் எதை சொன்னீங்க மேடம்?
செகண்ட் இயர்ல இது தேர்ட் ப்ரோக்ராம்ல சார். உங்களுக்கு கிட்டத்தட்ட 15th பிஜி ப்ரோக்ராம் இது.
அப்ப 50 முடிஞ்சிச்சு மேடம். இது எவ்ரி மந்த் போயிட்டு இருக்கு. அதாவது எவ்ரி வீக் போயிட்டே இருக்கு ரெகுலரா.
ஓகே.
பட் மேடம் உங்க வாய்ஸ் கொஞ்சம் லோவா இருக்கு மேடம்.
அப்படியே சார்?
கொஞ்சம் நீங்க டைரக்டா நீங்க எடுத்துட்டு நேரா இது பேசுங்க
சார்.
இப்ப கிளியரா இருக்கு.
ஓகே சார், அப்படியே வரேன். ஓகே, I'll come that way sir. ஓகே சார்.
அது நல்லாவே இருக்கு மேடம்.
ஓகே சார்.
நல்லா கவனிங்க மேடம்.
Jennifer, be cool. We'll be asking questions to you, Radhika and Gopika too. Okay? Answer one at a time. And if you don't know also, it's nothing. It's only a teaching session. So you need not know everything also. Okay? And your case sheet is excellent. So you'll definitely, if you read out the case sheet itself, half the program is over. Okay? Just be cool. And some common questions only we'll be asking. And you have your chief with you, who's going to ask the very easy questions to you only. Okay, Jennifer, it's only a teaching session. Need not be worried at all.
I know Dr. Lakshmi Velmurugan, she would have asked all the possible questions by any
examiner. I will ask all the possible questions, but I won't expect answers from her, sir.
No. I know. I have listened to your classes and when you are taking.
We missed you in the intensive care training, sir.
Yeah.
Usually you used to come, and this time you had to come.
Yeah, I was not there.
So all Jennifer, all Radhika, all rhyming irukku. Radhika, Gopika. Super.
Dr. Babu sir, they are your students. They are your students.
Yes, sir. It's the same hospital premises only, sir. They are in the hospital premises in various rooms.
Okay.
Thuthukudi is last time also the presented a very nice case presentation.
Yes,
I
sir.
think
Thank you,
Dr. Anand, no, that's a very good taskmaster. I think he'll train like anything.
Huh?
Dr. Anand.
Anand, yes, sir. Anand. He's a assistant professor.
Yeah. Sabhi Gopal, welcome.
Gopal sir, good evening.
Microphone. Unmute. Dr. Gopal, good evening.
Good evening, sir.
Sir, good evening, sir.
Gopal வந்து 7:30 தான் கரெக்டா ஆன் பண்ணுவார்.
Sir, good evening, sir.
Good evening. Good evening.
Gopal sir, good evening, sir.
Good evening, sir. Good evening, sir. Sir, good evening. Good evening, sir.
Good evening.
Good evening, sir.
கோபால் வாட்ச் நைஸ், நல்லா இருக்கு. என்ன வாட்ச் இது?
இது ஆப்பிள் ஐ வாட்ச்.
சூப்பர் சூப்பர், கலர் நல்லா இருக்கு.
அவ ஹேர் ஸ்டைல் பாருங்க சூப்பர்.
சார் நீங்களுமா?
எனக்கு ஹேரே இல்ல, அதனால கொஞ்சம் ஜெலசி.
பட் அவர் உண்மைதான் சொல்றாரு கோபால்.
சூப்பர்.
Jennifer, good evening. Can you hear me?
Yes, sir.
Yeah. You are comfortable?
Yes, sir.
In front of all these big people, right? Don't worry. Gopika and Radhika. Is Radhika or Radhika?
Radhika, sir. H-A.
H-A. Radhika. Okay. And Gopika. Both are your same batch, no? Final year exam.
Yes, sir.
Radhika, R-A-T-H-I-K-A da varum. Maybe numerology played, I think.
Yeah, like our Jaya Lalitha.
சொல்லுங்க ஹரி.
DNB cardiology, DM cardiology students, I was taking a class on malpositions. So I spent 30 minutes in taking a class, and I thought I did a good job. But finally, this 30 minutes, there was no connection. So it was the anti-climax. So I am a little worried. So I am keeping my cell phone also ready. So in case, and as madam was requested,
That was a catastrophe.
It's really catastrophe. And so I am keeping that ready. And hopefully, because madam had called me in the morning. Lakshmi was calling me in the morning, and
Ramesh,
we will have a discussion.
Good evening, Ramesh.
Rama madam, welcome. Ramesh.
Hi, Rama.
Madam, you have muted.
Hi, Rama. Pleasant surprise.
Good evening. Good evening, ma'am.
Good evening, ma'am.
Good evening, Rama.
Ramesh sir, good evening.
Ramesh sir, good evening.
Good evening.
Good evening, sir.
Rama madam, good evening.
Good evening, sir. You all had a great time in Noida, I was told.
Yeah, excellent time. Especially with two ladies, Dakshani and this thing, So
good evening, madam.
fantastic.
Emma, madam.
Sir, good evening, sir.
எப்படி இருக்கீங்க மேடம்? நல்லா இருக்கீங்களா?
நீங்க sir, நீங்க எப்படி இருக்கீங்க
Yes,
sir?
madam. I am at Thuthuri Medical College, madam.
Oh, okay, sir.
Associate professor.
Very good, sir.
நாகலட்சுமி மேடம் எப்படி மேடம் இருக்காங்க? நாகலட்சுமி மேடம்.
ஞாபகம் இருக்கு உங்களுக்கு?
டாக்டர் நாகலட்சுமி உங்க க்ளோஸ் ஃப்ரெண்ட்.
ஆமாமா, நாகலட்சுமி வந்து பிரைவேட் பிராக்டிஸ்ல தான் இருக்காங்க சார், கோயம்புத்தூர்ல. அவங்க ரீசெண்டா பார்ட்டி ஆயிருக்காங்க போன மாசம்.
Yes, madam. You both are very close associate, madam.
Very close.
Madam belonged to my unit, and at that time I noticed both of you are very close.
Correct. Both of us were having children and we had to study with that. Adanala stories.
Right. Glad to meet you, madam.
Yeah, same here.
Good evening, Ramesh.
Doctors, please start the session.
Yeah, good evening to everybody. On behalf of IAP TNC, I welcome one and all, and we'll start with the pediatrics in prayer by Dr. Gopal Subramaniam, our IAP treasurer.
Thank you, sir. Good evening, one and all. We'll start today's DAP program with the pediatrician's prayer. குழந்தை மருத்துவனின் இறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும், நோயின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படி சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர்களின் குடும்பத்தினரும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி முதல் பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதர்களா என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும், நல்லவற்றை உள்வாங்கவும், மாற்ற முடியாதவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான பெயரும் பொறுதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். நன்றி.
Thank you, Dr. Gopal Subramaniam, and I respected our President, Dr. Ramesh Babu, and our Treasurer, Dr. Gopal Subramaniam, and President-elect Dr. Suresh Balan, and President 2021, Dr. Muhammad Ismail, and Vice President, Dr. Annamalai Vijayaraghavan sir, and Joint Secretary, Dr. J. Balasubramaniam, and AAA, Dr. Thirumurugan Sarane, and Editor, Dr. R.V. Dashani, and other central EB and as well as state EB members. And on behalf of IAP TNSA, welcome one and all. First, I welcome our today's chairperson, Dr. Zulfikar Ahmed sir. He is known cardiologist and a renowned teacher also. He is currently a consultant pediatric cardiologist, KIMS Hospital, Trivandrum, and he is adjunct professor of cardiology, KMC Manipal. And I welcome today's moderator, Dr. Lakshmi Velmurugan. She is a professor of pediatrics, Institute of Child Health, MMC. And I welcome my friend as well as my unit mate, Dr. A.S. Babu Kandakumar. Currently, he is Associate Professor of Pediatrics, Government Thuthukudi Medical College. I welcome all the judges, Dr. Janani Shankar, Chennai, and Dr. P. Ramachandran sir, Chennai, and Dr. S. Ramesh from Chidambaram, Dr. Rama Chandramohan from ICH Stanley Medical College, Dr. S. Srinivasan from Pondicherry, and I welcome all the central as well as state EB members. On behalf of IAP TNSA, I welcome today's case presenter from Government Thuthukudi Medical College, Dr. Jennifer, Dr. Gopika, and Dr. Adhika. On behalf of IAP TNSA, welcome one and all. Our President, Dr. Ramesh Babu, has joined. Our President, Dr. Ramesh Babu, can you tell few words?
Good evening, sir. Good evening, Dr. Rajendran sir, for your introduction. Just I am traveling, no issues. Respected chairpersons of today's PG's teaching program, and respected moderators, respected judges. Sorry for joining a bit late. Our dynamic secretary of IAP TNSC is conducting this PG and UG teaching programs on alternate Saturdays for the benefit of the student community. I request all the postgraduates as well as the undergraduates in their alternate week sessions to attend the class without fail and get benefited for their exams, and then also to update their knowledge. I am very much thankful to all the judges who are participating in every week in their busy schedule for the benefit of the students. I thank once again the faculties and the judges, our secretary, Dr. Rajendran sir, for conducting this program without any obstacles. Thank you once again for the opportunity. Please proceed, Dr. Rajendran sir.
Thank you very much, Dr. Ramesh Babu sir. And I request our chairperson, Dr. Zulfikar Ahmed sir, please take over and proceed, sir.
Thank you, everybody. Again, I know we'll have a interesting session, hopefully, and a very friendly session, I think. Jennifer, are we ready?
Yeah, Jennifer, you can start to slide share and you can proceed. Before going to that, I request our moderator, Dr. Lakshmi Velmurugan, to tell few words.
Thank you very much, sir. I profusely thank our IAP TNSC President, Dr. Ramesh Babu, our very, very dynamic Secretary, Dr. Rajendran sir, Thirumurugan Sarayan sir, Gopal Subramaniam sir, for having given me this opportunity. This is going to be a real good session because Dr. Zulfikar Ahmed sir is our teacher. Though we have not met personally, we were like Ekalivas, all of us are going through his notes and studying, reading about his all notes. Now the session will be like this for the first 1.5 hours. It will be a purely case presentation, and all questions regarding exam questions and practical questions will be directed towards all the three speakers. At the end of it, our professor, Dr. Zulfikar, will then give us a 20 minutes session on probably the important aspects about it and about the congestive cardiac failure. I would again like to thank Zulfikar Ahmed sir and Babu Kandakumar sir for having, we'll be traveling for the next 1.5 hours with them. Hope we have a good session. Thank you, sir.
Thank you, madam. Now, Dr. Babu Kandakumar, please.
Respected office bearers of IAPT and MSc, respected judges, respected senior members, and dear students, good evening to all. On behalf of Thoothukudi Medical College, I thank the IAPT and MSc for giving the opportunity to present the case in this forum. Thank you, sir. With this, we will proceed with the presentation. Thank you, sir. Thank you.
Yeah, thank you. Dr. Jennifer, please proceed your presentation.
Good evening, one and all. I thank the IAP-TNSC for giving me this opportunity to present this case in the online session. Coming to the case, 11-year-old female child.
Jennifer, just before we begin, we will pause at each slide and then we'll go forward, right?
Okay, sir.
Okay, so we'll start.
Okay. 11-year-old female child, second born of non-consanguineous marriage, coming from Vedapatti. Her mother, whose reliability is good, admitted on 3/3/2022 with chief complaints of fever for 20 days, pain in both knee for 20 days, and breathlessness for 20 days.
Okay. No, go back to the first slide. So we'll take one by one. So you said small things. These are all very small things, but they may be important. You said old FCH. What is that? Female child. Female child. So it's always, you have an 11-year-old teenager. It is always better to call her a girl. No, he's an 11-year-old girl or 11-year-old boy, rather than making it sort of an inanimate object like female child and all, right? So I think it sounds better. It becomes more personal. You have an 11-year-old girl, right? Or suppose it is a very small baby, you can say a baby boy or a baby girl. That would be better. And second born of non-consanguineous marriage coming from Vedapatti, whose reliability is good, admitted on 3/3. That was some like 23 days back. 3 weeks back, she was admitted into your hospital, right?
Yes,
okay.
Sir.
Now, this fever for 20 days, all these 20 days, does it relate to the present time or 3/3/22?
Sir?
No, see, she was admitted on 3/3.
Yes, sir.
This 20 days of history of fever, pain, and breathlessness, does it is before 3 or after 3? In the sense, when she came to the hospital, was she having fever for 20 days?
Yes, sir.
So at the time of admission, so you can say very clearly that at the time of admission, she had fever for 20 days, pain in both knee for 20 days, and breathlessness for 20 days.
20 days.
Okay.
Okay.
That is what. So you mean to say that she had been having pain both knee for 20 days. Okay. Breathlessness for 20 days.
Okay.
So you have two joints with fever and breathlessness. So with this first slide, what comes to your mind? You know the diagnosis, but still. You have a 11-year-old child with a triad of symptoms: fever, joint problem,
pain,
and breathlessness.
Yeah.
So what will you think?
Post-streptococcal acute rheumatic fever, sir.
You needn't say post-streptococcal. You can say acute. You will think of an acute rheumatic fever with what? If you have breathlessness and if it is due to heart, so what could be the additional?
Heart disease.
Rheumatic fever.
Carditis.
Yes.
Carditis. Rheumatic fever with carditis. That is one possibility you should think of. Okay. any other possibilities, because this is the most likely possibility in an 11-year-old child. But still, you must have a broad canvas to draw. You must think of other possibilities also nowadays. So what are the other possibilities? Less common possibilities.
Viral myocarditis.
You will think of a viral myocarditis. Okay, I am writing it down. We will again go back to this. Okay. Then Gopika, any other thinking process? You have
infective endocarditis.
Exactly. Infective endocarditis is a possibility. So whenever we want to couple the fever with pain of joint and breathlessness, we attribute to cardiovascular system, because anyway, this is a cardiovascular case. So we should think of infective endocarditis also. Three possibilities you have brought. Three possibilities you have brought up. Which is the least common among the three in terms of commonness? Between rheumatic carditis, viral myocarditis, and infective endocarditis, which is least common?
Viral myocarditis.
I think infective endocarditis is least common. So this is very rare. But which has the highest mortality among these three?
Infective endocarditis.
Infective. So that is very important point. Okay. Anyway, so you are thinking about these possibilities. We may later on with your other presentation, we may have other possibilities also. Right. Go ahead.
One more question.
Yeah.
Fever for 20 days. What do we call that fever as? Acute, subacute, or chronic fever? See, you have got fever, pain in both knees, and breathlessness. You are thinking in terms of cardiovascular problem. Very good. Any other thing? Fever for 20 days, it is a what do you call it as? Acute, subacute, or chronic fever? Less than 7 days, we call it as acute fever. 7 to 14 days, we call it as subacute. More than 14 days, we call it as chronic fever. Chronic fever, apart from infections, what are all the other causes? It can be inflammatory causes. Very good, excellent. Any other cause? Can it be malignancies? Can ALL present with fever, pain in both knees, and breathlessness?
Yes, ma'am.
Yes, very good. Okay, so long duration fever or chronic fever, you should think in terms of infections, inflammation, malignancies, autoimmune diseases, and sometimes it can rarely be idiopathic. Okay, very good. In this child, you are thinking in terms of a rheumatic fever with carditis probably, or it could be a case of infective endocarditis you are thinking. Can you clinically differentiate these two things, infective endocarditis and rheumatic fever? Is it easy to differentiate between both of them, or it's very, very difficult? You can. Okay. During the course, see whether it is possible or not. Okay. Go to the next slide. Yes.
Of presenting illness. Child was a case of some acquired heart disease diagnosed in the year December 2020 and was on regular oral medication for the past 1 year. Then skipped drugs for past 3 months. Following which the child developed symptoms of fever, which was sudden in onset over a duration of 20 days with intermittent afebrile period for 7 days. In nature, intermittent, not associated with chills and rigor, no diurnal variation, relieved by medications.
Okay. So this child had some acquired heart disease diagnosed in the year 2020. That was 2 years, exactly 2 years back, and he was on regular oral medication for past 1 year. No, 1 year. No, 1 year. Right. Then the person skipped drugs for the past 3 months, and child developed all these problems. Okay, right. So apart from, basically we are talking about rheumatic fever. Naturally, we think this was the first rheumatic fever attack, and child would have been on prophylaxis or whatever, and she would have skipped and all. That is the possibility. But what are the other possibilities? What are the other diseases which would have been acquired condition, which would have been diagnosed in 2020? She is on medication orally for the past 1 or 2 years, and then skipped the drugs for few months and came back to the OPD or emergency. What are the conditions?
Cardiomyopathies.
Which cardiomyopathy?
Yes, yes, you're right.
It shows dilated cardiomyopathy.
Dilated cardiomyopathy. So you think of this is a very strong possibility. In 2020, she may have been diagnosed as a dilated cardiomyopathy, must have been put on multiple drugs and then skipped, and they come with the decompensation. So that is a very important possibility. What are the other cardiomyopathies that you know of, Gopika?
So hypertrophic obstructive cardiomyopathy, restrictive cardiomyopathy.
Hypertrophic, you can call it as hypertrophic cardiomyopathy. And third is the restrictive cardiomyopathy. Which is the least common among the three, Radhika?
Restrictive cardiomyopathy.
Restrictive cardiomyopathy is the least common.
Excellent.
And probably a dilated cardiomyopathy is most likely, right? Okay. Which is strong genetic influence, Gopika, among the cardiomyopathies? Among the three cardiomyopathies of DCM, HCM, and RCM, which has got the strongest genetic background?
Hypertrophic cardiomyopathy.
Hypertrophic cardiomyopathy. Okay. Suppose you have 100 dilated cardiomyopathies lined in on a line. How many will have some genetic basis, approximately? Or in other words, what is the percentage of genetic background in so-called dilated cardiomyopathy? Is it high or low or very low? What is your feeling? I mean, we are learning, no?
Yeah, dilated cardiomyopathy usually follows what disorder? Usually follows?
What is the condition where we discussed no acute conditions?
Usually follows a viral myocarditis. Usually follows a viral myocarditis. So the chances of it having a genetic predisposition is high or low. That is a simple. That way
it is relatively low compared to hypertrophic cardiomyopathy. The only point you should remember is that with advances in genetic modalities, we are slowly increasingly finding that the so-called DCM, post-viral myocarditis DCM, some of them have genetic basis. Maybe there is a genetically predisposed child, has a viral myocarditis, and then has a dilated cardiomyopathy. So that is one disease which would have been acquired on medication, dilated cardiomyopathy. Okay. Then any other acquired heart disease, acutely presenting acquired heart disease diagnosed in 2020, maybe on oral medication in an 11-year-old child. Any other acquired cardiac illness need not be a structure. Mitral valve?
Prolapse.
Mitral valve prolapse. What drug will we give for mitral valve prolapse? Why should we give a drug for mitral valve prolapse?
can they go in for sudden death? MVPS children, can they go for sudden death? No or yes? And what is it otherwise called as? MVPS is otherwise called as a mid-systolic click, mid-systolic murmur syndrome. What drug we give for prophylaxis? In with MVPS. Huh? Yeah, what drug?
Indomethax.
No,
mitral valve prolapse. We are talking about.
We are talking about 11-year-old child with MVP.
MVPS, mitral valve.
We are talking about indomethacin. Very dangerous. Now, suppose Jennifer, you have an MVP and she has repeated complaints of chest pain, anginal or non-anginal pain. She becomes very uncomfortable, especially at school. He may be studying in the 5th standard. So what drug will we usually give in our OPD? Beta blocker. You know, sometimes we give beta blocker for recurrent chest pain. So that may be one possibility. Then any other possibility, acute onset problem, non-structural problem. This may not be related to this present case, but non-structural. What is meant by non-structural? Electrical. Is there any electrical cause for arrhythmia? So for example, child had an acquired disease like an SVT diagnosed in 2020. Child should have been given some preventive medicine like a beta blocker. So the point is, even though we think we know that this is a rheumatic problem, whenever we think of an acquired heart disease diagnosed 2 years back on oral medication, we should think of all these conditions. One, a DCM. Now, of course, number 1 is rheumatic fever. Number 2 is dilated cardiomyopathy. As Madam said, MVP or recurrent chest pain, SVT on secondary prophylaxis. All these things have to be thought of. Even hypertrophic cardiomyopathy may be on a beta blocker. So all these are possibilities in this particular child. Why did you say indomethacin, Jennifer? I'm a little worried about that. No, I'm not making fun of you.
Probably she's doing her newborn postings now, sir.
This area, okay.
Okay. Jennifer, no problem. But are you using indomethacin for closure of PDA in children? Okay. What drug are you using? Some other safer drug?
Brufen or either Brufen or paracetamol.
Very good. Very good. Very
what
good.
What is Brufen?
No,
Ibuprofen.
Yeah. Very good. Okay. Okay.
Onset is sudden. Duration is 20 days. Intermittent afebrile, right? Low grade intermittent later. This is current presentation, not associated with chills and rigor. No diurnal variation. Relieved by medications. What kind of medication? Is it antipyretic or some other drug?
Antipyretics, sir.
Antipyretics. Okay, and say that. Okay, go ahead.
Okay. Jennifer, you rheumatic heart disease may be your case, but external examiner might ask you all questions apart from rheumatic fever. So to pep you up, one simple question: can you tell me some common causes of fever with rigor in children?
Malaria, infectious malaria.
Okay.
Kalazar.
Kalazar, where did you see? It's in West Bengal. Leave it. Then malaria, very okay.
Girl child.
Any abscess, UTI.
Very good. Urinary infection. Yes. Fever with rigor.
Any abscess.
Good.
Okay. Abscess pus.
In heart disease, infective endocarditis.
Okay. Thank you, Neem. For that indomethacin -5, I have added +5 to you now. Okay, very good. Proceed to the next slide.
Okay.
Will you consider rheumatic fever when the patient is having high-grade fever? Suppose the patient is having a fever of more than 104 degrees Fahrenheit. Will you consider rheumatic fever as an etiology for your joint problem?
Infective endocarditis.
My question: will you consider rheumatic fever when the patient is having high-grade fever, the joint symptom?
Fever has to be very high in rheumatic fever, or it usually mild or
more than 38.5 degrees.
It's always a low-grade fever. Now the patient is having high-grade fever, you have to revise your diagnosis or you have to reconsider. So that is a very important point as far as the rheumatic arthritis is concerned. What is the very close differential diagnosis for rheumatic fever? Very close differential diagnosis, you are
11-year-old girl.
Rheumatoid disease, rheumatoid. So this is a rheumatic fever, and rheumatoid, suppose a patient is having juvenile rheumatoid arthritis or idiopathic arthritis. What is the type of fever and what is the type of joint pain? What is the differentiating point?
Migratory migratory.
High-grade fever, less pain, is more diagnostic of juvenile idiopathic arthritis. Low-grade fever, very severe joint symptom. The diagnosis is more towards rheumatic fever. So that's a very important clinical point as far as the fever and joint pain concerned. Right? What is the definition for arthritis? When you say that a patient is having arthritis?
Associated joint
pain plus
when there is effusion with any two of the following: tenderness, warmth, and a restriction of movements.
Restriction of movement, one more.
Tenderness and warmth.
Painful movement, loss of motion, erythema, heat, or the patient is having intra-articular swelling. Suppose the patient is having intra-articular swelling itself is enough to make a diagnosis of arthritis. Otherwise, two of the following, as you mentioned, any two is enough to make a diagnosis of arthritis. That is a diagnostic point for arthritis, right? Okay, next slide, please.
Okay.
Serious onset over a duration of 20 days. Initially, child was non-ambulatory for first 1 week of illness. Then it was relieved by medication from the nearby private practitioner. Initially, it involved the right knee joint, then left knee joint, not associated with the swelling or redness, not associated with any other joint involvement, not associated with pain in small joints, not associated with the early morning stiffness, relieved on oral and parenteral medication.
Okay, very good. Is this enough? Jennifer, two important points I want in this slide which are missing. Can you just tell me?
Maybe Gobika can tell.
Radhika, anybody? Yes, please. Two very, very important points. One important point at least. Rheumatic fever, the arthritis usually, this is
migratory.
No, migratory, you mentioned the word at least, but you have said that it is initially right and then left knee. But most important point.
Severity.
Pain is excruciating, that is accepted. But pain is excruciating, and two important characteristic features of rheumatic arthritis is it heals without any residual deformity. For example, 20 days, there will be no swelling after 48 to 72 hours once you start the child on anti-inflammatory medications. Dramatic response to anti-inflammatory medications and healing without any residual deformity. These are the two characteristic features of pain due to rheumatic fever. Are you able to understand? So the child had no residual deformity at the end of 2 years. That should have come in your this slide. Right, Gopika? Yes.
Radhika, Madam was talking about this, what do you call as non-deforming arthritis. Rheumatic fever is a classical example of a non-deforming arthropathy. Can you think of other non-deforming arthropathies? What are the other causes, or at least one cause of non-deforming? JIA is a deforming. Correct. Very good. SLE is a very classical example of a non-deforming arthropathy. Rheumatic is very good. See, sometimes people say there is one particular kind of rheumatic fever which has got some deformity. Somebody's name is given to that.
Yes, please.
Yakut's arthropathy.
Yakut's arthropathy. Okay.
Very good.
I don't know whether it exists or not, but I think it is a very important question.
Yes.
And the answer is correct. Good.
Very good.
So you have two joints only. So now you have only two joints. Will you call this? What will you call this? Will you call this polyarthralgia or oligoarthropathy? How many joints would you require to call it as polyarthropathy?
More than
5.
More than 5. That's a big number, no? 4 or more is enough, no? Even rheumatoid arthritis, JIA, what we need is 4 or more. So sometimes in rheumatic fever, you may not get actually 4 joints, 3, 2, all this will be possible, but no associated with the swelling. Another very practical point you should know that, especially in Kerala, where there is in Tamil Nadu also declining rheumatic fever. Many rheumatic fever nowadays come with only polyarthralgia, not much of an acute arthritis, which we used to see when we were MD students. That is why the new generation postgraduates say sometimes even miss acute rheumatic fever. Then you said a very important point, not associated with any other joint pain. In particular, what kind of joint involvement would be against a rheumatic fever? Jennifer.
Sir is asking what are the joints which are usually not involved in rheumatic fever?
Small joints.
Yeah, like what? Which are the smaller joints? What are you talking?
Phalangeal joint.
Interphalangeal joints. Okay.
Interphalangeal joints.
Okay. Whatever. That is one smaller joint. What else?
Mandibular joint.
Which one?
Mandibular joint.
Temporomandibular or TM joint. Okay. Right. Then more importantly,
hip joint.
Hip joint, spine.
Spines, no? Spines and hip joints. Very unusual to have a joint. So sometimes you get rheumatic fever, you get smaller joints also, but spines and hip, I think, is practically very difficult to find this. Not associated with the early morning stiffness. What is the relevance?
In juvenile idiopathic arthritis.
Right, it can have morning jelly. Okay, right. Next slide.
Okay, 1 minute, Radhika. This arthritis. Now, can this child's slide or this child symptoms can be taken as a major criteria? The major criteria for Jones. What are you having? You are having only polyarthralgia or polyarthritis or monoarthralgia. What are you having in this child? Can this be a major criteria? That is my question.
Not polyarthritis, not present.
Okay. Okay. Child is having monoarthritis or monoarthritis? Huh?
Arthritis.
Child is having monoarthritis. Okay. Can that be taken as a major criteria? As per the latest 2015 Jones criteria, can this be taken as a major criteria? Yes, Radhika?
Moderate to high risk population, it can be considered as a major criteria.
High risk country or a low risk country?
High risk country.
Okay, what do you mean by high risk country?
Incidence of acute rheumatic fever more than or equal to 2 per 1 lakh school going children.
Excellent, Radhika. So you are a high risk country, and so can this be taken as a major criteria at present?
Yes, ma'am.
Yes, you want to take it as a major criteria. Okay, good, very good. Proceed.
Radhika,
the usual duration
Radhika, can I add one more point?
Yes, yes, sir.
Radhika, in Tamil Nadu and Kerala, what do you think is the prevalence of rheumatic fever in children, school-going children? Is it relatively low or relatively high now?
Relatively high, sir.
No. It is relatively very low. See, many of your studies from Tamil Nadu, many of the studies from Kerala for the last 20 years have shown that the prevalence has come down to maybe less than 1 per 1,000 or maximum 2 per 1,000 school children, which means that if you apply that AHA guidelines, at least Kerala and Tamil Nadu, where we have real data, may be considered as a low risk area. So that is a contentious issue, whether we should consider to our states. It is parochial, but our states are generally, I suppose, we come under the what you call a low risk area, because most of the studies, Vellore study, and many studies from Tamil Nadu, Kerala, I think you should go back and read about at least the last 20 years. You should look at the prevalent studies on rheumatic fever in South India. Anyway, go ahead.
Very good.
I want to add one more point. What is the usual duration of rheumatic fever arthritis, rheumatic arthritis? What is the usual duration? How long it lasts?
1 to 3 days. Each joint 1 to 3 days.
Sometimes the duration may vary from hours to days. Sometimes the pain may last for only hours, and sometimes the pain may last for days together. Sometimes without any treatment, the arthritis entirely subsides, and other extreme form, the patient may have to continue to have arthralgia and arthritis for sometimes months together. These are the various types of presentation rheumatic arthritis. Sometimes the pain may last for only few hours, and that is also taken as an evidence for rheumatic arthritis or arthralgia. This is a practical point.
Dr. Zulfikar, can I ask a question to the presenters?
Yes, please. Please.
Jennifer, can you think of Kawasaki in this case? If yes, what are the points in favor of it? If no, what are the points against it?
Sir, conjunctivitis.
No, is it likely or less likely? First answer
likely,
that.
Sir. Likely, sir.
Likely, I see. So you tell us why you think it is likely. 11-year-old child in Tamil Nadu having fever, joint pain, and what else? Breathlessness. You are thinking of Kawasaki disease and you are saying it is likely. So you have to defend. You need a real defense system. Tell us. Why? Give me 2 points why you say this is likely.
Sir, age group, sir.
Age group is in favor or against?
Age is against.
What is the age group of Kawasaki disease? It is less than 5 years.
Usually,
less than 11 years. And she was 9 years when she had the first problem, right? So that is against. What else? Anything positive? Anything for your support? Can Radhika or Gopika come to her support?
Fever more than 5 days.
Fever
more than 5 days.
Okay. Fever more than 5 days. There are very thin ice you are skating on. Anyway.
Otherwise, not fitting into Kawasaki criteria, sir.
Okay. Because your response to Ramesh sir's question was very quick, and you are very what do you call very firm. No, it is likely. So be very, very careful. Kawasaki. You can have a typical Kawasaki in an 11-year-old child, but not this patient.
Okay, it's a little unlikely, Jennifer. Can we go to the next slide? Yes, please. Time is 8:05. Yes, please. Next slide.
Oh, 8 o'clock. I see.
5, 8,
You are not. No. Okay.
Yeah. Duration is 20 days. Progression is progressive in nature. Initially, the breathlessness was on during exertional activities. Progress to breathlessness during normal day-to-day physical activities. Now, breathlessness at rest for the past 1 day.
You would like to classify this breathlessness, and 2 important things you have not added to this history. Whenever we talk about breathlessness, NYHA classification, we always bring them to. And one more, two things which we usually follows breathlessness. We add 2 points. Maybe you're bringing it behind, I don't know. But usually you should talk about orthopnea and paroxysmal nocturnal dyspnea at this point of time itself. And you should classify. Can you classify a NYHA classification for this one? Jennifer?
NYHA class 1 exertion, no exertion or unaccustomed activities.
This scale is having what classification? Gopika?
No, Jennifer, madam is asking, what is the NYHA class of this particular girl?
For this particular child, what is the classification?
Can you hear me?
Yes. Radhika, Gopika, no problem.
Class 4.
Yes. Yes.
Ma'am, here class 4, ma'am, breathlessness more than ordinary activity.
Okay. At the end, it was breathlessness even at rest for the past. So that comes under grade 4. And is there any orthopnea or paroxysmal nocturnal dyspnea for this child?
No, ma'am.
No orthopnea, no PND.
Yes, ma'am.
Okay. Yes.
PND, what is the relevance of PND in cardiology, Radhika? Why is it PND very, very important in the cardiovascular system?
Indicates a left ventricular failure, sir.
Exactly. It is almost exclusively due to LVF. Whereas even orthopnea can even get an asthma and all, but never PND. So PND means you have a left heart disease. I think that is a very important physiological point that Jennifer has. Oh, was it Radhika? Anyway, okay, go ahead.
Next.
So she was our class 4, near class 4 at the time of admission into our hospital. Okay, go ahead.
Go ahead.
Initially, the child was taken to a nearby private general medical practitioner for the above complaints. They are given some injection on oral analgesics and advised to review in government hospital. As the intensity of the fever and the joint pain settled, she didn't came for follow-up. Now, for the past 2 days, the severity of the symptoms progress and the child was brought to our OPD.
Very, very typical. Yes.
History of EC fatigability present for the past 1 week. History of palpitation present for past 2 days. History of abdominal pain for the past 2 days, which was insidious in onset, non-progressive, more in the epigastric region, not associated with the food intake, not associated with abdominal distension, and no relieving factors. No history of cough, no history of hematosis, no history of chest pain. No history of...
Go back.
No, you can go back to the, yeah, we will keep this. History of palpitation, was it a paroxysmal palpitation or an exertional palpitation? Which would you expect in this patient? In this patient, will you expect a exertional palpitation or a paroxysmal palpitation?
Paroxysmal palpitation.
No. You expect, see, basically exertional dyspnea, exertional fatigue. So naturally you will expect a exertional palpitation, because paroxysmal palpitation means either an SVT or an AF, which is very, very rare at this age group with a rheumatic problem. Abdominal pain, I can understand. You are basically trying to tell us that it may be because of a tender liver and all, right?
What is the cause of abdominal pain you're thinking, Radhika?
Just hepatomegaly.
This is a tender, because tender hepatomegaly. Okay, and this I mean at this point of time I object to this no history of hemoptysis, because hemoptysis is a very, 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 very rare symptom in rheumatic heart disease in children. Probably why did you have so many other things we'll have to ask Major criteria you have to ask other history for congestive cardiac failure. Only then cough I accept, because you can have, even in CCF you can have cough, but hemoptysis, why did you ask suddenly? What did you have in mind to ask for hemoptysis? And what is the commonest cause of hemoptysis in children? Yes. The cause of hemoptysis. Why did you ask for hemoptysis? And what are the cause of hemoptysis in a case of rheumatic heart disease? Since you have asked, I am asking.
Pulmonary congestion.
Pulmonary congestion is a pathological term. Pulmonary edema, okay. Edema, pulmonary infarction, rupture of bronchopulmonary anastomosis, pulmonary apoplexy. All these will occur in which condition?
Mitral stenosis.
Mitral stenosis. Is mitral stenosis common in children? It is it takes a long time for mitral stenosis to occur. So you might probably, the child would have crossed the 12 years by the time you see mitral stenosis. I am not telling it is very, very rare, but it is uncommon in children. So this hemoptysis, which usually occurs in mitral stenosis, is very unlikely. You should have brought out all the major criteria now and then come to hemoptysis, right? Good. Okay, proceed. And most important thing, here you have asked for history of chest pain. Chest pain in children, common causes, and chest pain in rheumatic heart disease. What is the probable cause? If a child in a rheumatic, yes, is carditis,
pleural effusion, pericardial effusion.
Pericarditis. There is no chest pain. Once
pericarditis.
Pericarditis. Very good. Excellent. What is the type of chest pain? It has any relationship to inspiration, expiration, or it comes on exertion? It is relieved by medication. Okay. Yes. Okay. Pericarditis, it produces chest pain. It is exacerbated by inspiration usually. Okay. Okay. Then
Natika, we talked about, Madam was saying about the very rare occurrence of children having rheumatic mitral stenosis. What is it called? What is the term used?
Mitral stenosis.
Mitral stenosis in the young. What is it called? There's a technical term for that. Any adolescent below 18 or below 20 years having rheumatic MS, we give a particular name. Any idea? Okay, you should know that this is called a juvenile mitral stenosis. The term is juvenile mitral stenosis. This is very important because one of our Indians, Sujoy Roy, who was a cardiologist in All India Institute, was the first person to describe this particular terminology. And there are clinico-pathological differences between juvenile MS.
So your audio is breaking. Can you hear me, Jennifer?
Yes, ma'am.
Okay. Sir's audio is breaking. By the time it comes back, now I would like to ask you a few more questions here. What are the common cause of chest pain in children as such? A cardiac or non-cardiac? In adults, what is the commonest cause of chest pain?
Myocardial infarction.
Can I be heard?
Yes, sir. Yes, sir. Now we are able to hear. In adults, myocardial infarction or angina is a common cause of chest pain. Very good. In children, cardiac cause of chest pain are more common or non-cardiac cause of chest pain are more common. And tell me few cause of chest pain in children. Gopika? Yes. Costochondritis. Muscular costochondritis. Yes, very good. Yes. And then any other cause? Can pleurite produce chest pain in child? Yes. Can pericarditis produce chest pain in
pericarditis? Yes. Pericarditis.
One another favorite answer expected by examiners. One more answer about this chest pain in children. One rare cause. Any other cause?
Alcap.
Oh, very good. Anomalous origin of, what do you mean by Alcapa?
Anomalous origin of left coronary
artery from right. Excellent. Okay. So common cause of chest pain in children is non-cardiac. 90% of your chest pain in children is non-cardiac. Okay. Go. Proceed to the next slide. Proceed to the next slide. Yes.
No history of orthopnea. No history of
have come earlier, right? Okay. Yes. Then.
No history of orthopnea. No history of paroxysmal nocturnal dyspnea. No history of swelling.
One more question, Jennifer. What is meant by tropical mitral heart disease? What is the normal age at which rheumatic mitral stenosis usually presents? And what will happen in a patient who are living in the tropical countries?
It will take years to develop mitral stenosis.
Okay.
In tropical countries, there is increased incidence of recurrence of rheumatic fever. So, patient at even at a younger age may develop mitral stenosis. That is called as tropical mitral heart disease. It is seen in children, those who are living in tropical countries. That is called as tropical mitral heart disease. That indicates mainly mitral stenosis due to rheumatic event.
Babu sir, இதான் நீங்க அங்கேயே சொல்லி கொடுத்துருக்கணும்.
Okay.
Okay, very
good. Jennifer.
Yes, yeah.
Jennifer.
Hello, sir.
Can you hear me? Yeah. See, the basic thing is that generally in the Western population, the latent period between acute rheumatic fever and MS happens to be between 10 and 20 years. So what sir is implying is that in tropical countries like India, the latent period between the first attack and the rheumatic MS may be as low as 2 years. 2 years. Even 2 years can produce an MS. That is what is the difference between these tropical countries and the temperate climate. Okay. Go ahead.
Okay. Next slide. Next slide.
Why
can
did you see
cyanosis in mitral heart disease? Severe mitral stenosis. Can you get cyanosis? Yes or no?
Yes.
Okay. Okay.
Pulmonary.
No, is it peripheral cyanosis, central cyanosis?
Central or peripheral cyanosis? What type of cyanosis? Suppose you are right, but yes.
Central.
There's a clue in madam's question. Central or peripheral? So
Central.
No, peripheral. You cannot have a central cyanosis in a valvular heart disease. So it has to be peripheral.
Peripheral.
Okay.
The severe mitral stenosis, you can have a peripheral stenosis. Okay. Peripheral cyanosis. Sorry. Go to the next slide, please. 820. Yes. Yeah.
No history of involuntary movements, no history of painful finger ends, no history of rash, no history of any skin nodules, no history of convulsion, focal weakness, headache, or any visual disturbances.
Okay. This slide, you could have done it a better way, Jennifer, because you should have grouped all the major criteria. For example, involuntary movements, rash, chorea, all the major criteria. No, you could have told. Then you should have come to the complications like infective endocarditis, convulsions, and all that. That would have given a better understanding for us. Okay, we'll start with involuntary movement. What involuntary movement you expected in this child? What were you looking for?
Chorea.
Looking for chorea. Can you describe chorea?
Rapid, involuntary, semi-purposive movements.
Yes.
Associated with emotional disturbance, poor school performance, and relieved on while doing activities and relieved by sleeping.
Relieved during activity. In fact, it will become more during activity because that's why child always tries to keep its hand like this. It increases during activity, but definitely disappears. All involuntary movements disappears during sleep. That is very correct. Okay. Then what do you mean by painful finger ends? What did you want to look for? Why did you look for? To rule out, what do you mean by that?
Infective endocarditis.
Okay. Rash you look for in this child. Okay. How common is rash in rheumatic fever, Gopika? What is
rash? Rash, erythema marginatum, it is less than 1% only.
Excellent. Okay. Where do you look for it?
Trunk and back, ma'am.
Okay. Have you ever seen it?
No.
No, nobody has seen it. Okay. It's very, very rare. But if you are going to look for it, what sort of a rash it will be?
It will be macular with central clearing and peripheral serpiginous area.
Rash okay. But very, very, very rare. Okay. It is less than 1%, as you rightly said. Okay. And we are all dark skinned individuals where it is very difficult to make out a rash. Okay. Yes.
Next slide.
child was hospitalized 1 year back for the complaints of fever and joint pain involving both the knee joint for a duration of 2 days, not associated with the history of breathlessness, hospitalized and found to have heart disease. Duration of hospitalization was 10 days and advised to continue oral medication at discharge. 2 kind of medication, one tablet twice a day and another tablet to be continued for 2 months. Child was on regular follow-up. Child took regular oral medication for the subsequent 1 year and discontinued treatment for the past 3 months. No history of cardiac surgery, blood transfusion, any drug allergy, no history of recurrent respiratory tract infection.
Okay, very good. What you have, what were the probable 2 medications child was on from the history, you have taken a very good history, but what do you think the 2 medications were?
Secondary prophylaxis.
Twice a day child was getting 1 medication. What is the likely medication? It must be?
Penicillin, ma'am.
Penicillin?
Tablet penicillin. 250 mg, 1 BD.
1 BD. Okay. Prophylaxis is 250 milligrams, 1 BD. So this child, the weight of the child probably must be 250 milligrams, 1 BD.
Yes, ma'am.
27, 30, 25. Okay. Prophylaxis you have given. What is the other medication?
Anti-inflammatory medication, ma'am. Steroid.
Child has continued steroid for 2 months. Okay. You think it is steroid and the other one medication is penicillin. Now, in this past history, what you should have asked, and one more history, supposing it's a first attack, this is a recurrence probably, but if it's a first attack, what are the 2 things which you usually look for and ask in the history? You went on telling it is post. Yes, very good. Yes, you didn't ask for history of sore throat. Did they have history of sore throat? Is it important?
Yes, ma'am.
Yes, Gopika, anything else? History of sore throat and then uncommonly any other streptococcal infection?
Scarlet fever.
Okay, history of scarlet fever, how will you look for? Any clinical findings for scarlet fever which you know of and which is which is easy to make out?
Criteria.
Tongue you will see. What will you see in the tongue in a child with
strawberry
tongue? Okay, white strawberry, red strawberry, whatever you want, you can look at the tongue. Okay, by itself that is an indication of a streptococcal infection. Okay, now and you didn't ask for history of skin infections. Why skin infections? Streptococcal skin infections, do they produce rheumatic fever, or it's not very unlikely? It's not uncommon. It is uncommon.
Mostly they are nephrogenic strains, ma'am.
Okay. Acute glomerulonephritis, and they don't produce acute rheumatic fever.
Very less.
Or less incidence of rheumatic fever following skin infections.
Less, very less incidence, ma'am.
Why? That's why I'm asking. What happens? Why? Because the skin infections usually produce less antibody response to GAS infections, and the neutralization of the streptococcal toxin by skin lipids also happens. That is why we don't get rheumatic fever commonly following skin infections. Again, here one common question I usually ask is, how do you treat a streptococcal sore throat? As a PG or whatever it is, you should know this. How do you treat streptococcal sore throat? Treatment.
Oral penicillin before 9 days.
What do you mean 9 days? What is that?
How do you treat?
Penicillin.
No.
So I got choice.
Why 9 days?
9 days of.
What is the sanctity about 9 days, sir is asking?
Yeah, correct.
Number. Why suddenly you're telling 9 days? Okay. Usually you want to give penicillin 250 milligram QID for 10 to 14 days. You want to give for 10 to 14 days. Or you want to give injection benzathine penicillin?
Single dose.
Okay. But are you giving penicillin for treating streptococcal sore throat? What are the other drugs which can be used for treating streptococcal sore throat? Penicillin is 250 milligrams QID, you are right. But we don't commonly do it now. But what are the other drugs which can be used?
Drugs, erythromycin.
Okay, erythromycin you can give, yes.
Amoxicillin. Other penicillin group, amoxicillin.
Yes, very good. Yes, you can give amoxi, or you can also give allergic to penicillins. You can also go in for erythromycin. But the duration is how many days? It's not 9. It is 10 to 14 days. 10 days. At least 10 days you have to give. For pneumonia, how long? How many days you'll give amoxicillin? Pneumonia is a serious infection, so you'll have to give it for more days or less days.
More days, ma'am. 72 hours fever free.
Pneumonia
72 hours fever free.
Pneumonia treatment with amoxicillin for 5 to amoxicillin or whatever appropriate drug which you are using is usually for 5 to 7 days. But treat upper respiratory infection, pharyngitis, tonsillitis for 10 to 14 days. Okay, right. Okay, go ahead.
Jennifer, one point I want to tell, because Jennifer was interested in this 9 days business. No? So the reason, I mean, she got some information about this 9 days. The point is, there have been studies saying that if you have a streptococcal infection of the throat, and if you treat with penicillin within the first 9 days, it is likely to prevent rheumatic fever. There's a paper. That is why she was enamored by this 9. Okay. Okay. No, go ahead.
Don't look stressed, Jennifer. You're doing a great job.
Yeah, exactly.
You're doing very well. Don't look stressed. This is a super specialist who is asking you a question. Zulfikar sir is a super specialist.
Nothing like that. Okay, go ahead.
General pediatrician. So we are going in our own way. No, you are doing all three of you are doing an excellent job. Please proceed. Yes. Go.
Treatment history. Currently, the child was admitted in our PSU. Started on tablet penicillin, 250 mg QAD, and oral steroid 2 mg per kg in divided doses, along with antacids and anti-failure measures, IV lancet 2 mg per kg divided doses, AC inhibitor tablet enalapril 2.5 mg 1 OD, and tablet digoxin 5 microgram per kg OD. And patient responded to the treatment, and child was weaned from O2 on day 4 of hospitalization and discharged on day 13 of hospitalization.
Okay, sir, shall we discuss the treatment later, sir?
Yeah, please.
Next slide.
Next slide.
Let's go to the next slide.
Antenatal.
Okay, please leave antenatal, needle, anything particular? For this child with 12 years old child, anything particular? Child is a regular school going child, developmentally normal.
Normal. We'll skip this slide. Yeah.
This slide and the next slide also. Okay, please. Okay. Next slide. Yes. Yeah.
Developmental history, attained age appropriate milestones, now studying in 5th standard, good scholastic performance, good peer relationship, immunization history, immunized till 10 years of age, no optional vaccines given.
Okay, right. Go ahead.
Go ahead.
Because we will reach this.
Family history, elder sibling is alive and healthy, no history of any cardiac disease, stroke or muscular disorder.
Jennifer, why do you want to say elder sibling is alive and healthy? Elder sibling is healthy or what? No, she has to be alive, no? Okay, go ahead.
No history of cardiac disease. Okay. Yes. Okay, 610 calorie deficit and 6 grams of protein is deficit. Okay, sir, is that taken, ma? Babu, sir?
Sir. I mean, sorry.
What is the importance of nutrition is in a cardiac patient?
Cardiac is there will be increased basal metabolic rate and decreased intake, so nutrition will be less. In other rare causes like kwashiorkor, there will be cardiomyopathy, and in case and disease also cardiomyopathy.
Okay. Okay. Yes. Good. Proceed.
Okay. Go ahead. Yes.
Contact history, no history of contact with open case of tuberculosis.
Okay.
Socioeconomic history, nearby healthcare center 7 kilometers from my residence.
So, what is the important socioeconomic history? What are the 2 important points we have to consider while treating a patient with rheumatic fever according to this? Pardon? Not audible. You are.
Others can.
Overcrowding and hygiene.
Okay.
Poverty and overcrowding. So you have to find out what is the patient's socioeconomic status. Is there poverty is prevailing and overcrowding? And one more point is common in urban slums. What is the residing area of the patient is also important. So these are the things to be considered while treating a patient with rheumatic fever. And you have to make a correction during the subsequent follow-up visits also. Right. Next slide.
Yes, next slide. Next slide, Jennifer. Right. Yeah. And Radhika, her audio becomes better. Yes, can you read it?
11-year-old female child, second born of non-consanguineous marriage, developmentally normal with insignificant antenatal, natal, and perinatal history, who was diagnosed previously with some heart disease 1 year back, on some oral medication for subsequent years, with poor blood compliance, with history of fever and joint pain for 20 days, progressive breathlessness for 20 days, palpitations, easy fatigability for 1 week, with complete immunization status, with calorie deficit of 610 kilocalories and protein deficit of 6 gram, belonging to upper lower socioeconomic class.
You both are using two systems. Please disconnect one system because it was echoing. Okay, next slide.
Provisional diagnosis, probable system involved is cardiovascular system. Provisional diagnosis, a case of acquired heart disease, probably of rheumatic etiology, with the symptoms suggestive of congestive cardiac failure, with the history suggestive of rheumatic reactivation.
Okay.
Right.
Yes.
Okay. This is the historical. Now we are interested in the physical findings. Okay, go ahead.
General examination, child examined on day 2 of admission. Child conscious, oriented, thin built, afebrile, dyspneic at rest, no pallor, no interest, no cyanosis, no clubbing, no pedal edema, no significant lymphadenopathy.
Okay, yes.
Vitals, pulse rate 120 per minute, regular rhythm, large volume.
Collapsing pulse. Okay.
No radial or radiofemoral delay, felt equally in all peripheral vessels. Respiratory rate 36 per minute, abdominothoracic type of breathing. Saturation 98% in right upper limb on oxygen support. BP 90/50 millimeter of mercury in right upper limb, 90/60 in left upper limb, 120/70 in right lower limb, and 120/70 in left lower limb. Pulse pressure is 40 millimeter of mercury. Temperature 99 °F, and JVP is 8 centimeter.
Okay, and I am interested in this particular slide, Jennifer. Okay, because you have covered pulse, blood pressure, as well as JVP, which are the very important things in cardiology. Pulse rate is 120 per minute, regular, large volume collapsing. What is meant by large volume? Is it what you meant was a high volume or large volume? What you meant was high volume, right?
Yes.
You meant high volume collapsing pulse with no radial or radiofemoral delay, felt equally in all peripheral vessels, right? I agree with you, which means you are having a what you call as an aortic runoff. Now, your BP in the upper limb is 90/50 in an 11-year-old child. Do you think this BP is compatible with your high, what you call high volume collapsing pulse? Do you think so? I am very much surprised because in the left upper limb, it is 90/60. The pulse pressure is only 30, and 90 is low for this girl, definitely. But you are getting a high volume collapsing pulse, so they are absolutely incompatible. Sorry to say that. So the point is, between this pulse and the blood pressure value, which is more reliable according to you? Because you have taken all this. So which will you trust more, BP or your impression of a large volume collapsing pulse? Jennifer, did you understand, Jennifer? See, Jennifer, can you hear me?
Yes, sir.
See, in a rheumatic heart disease, chronic rheumatic heart disease, getting a reactivation, apparently. And if you have a large volume, or otherwise called high volume collapsing pulse, it means that you are definitely thinking of an aortic regurgitation. Maybe there is an MR differently, but you are thinking of an aortic, because high volume collapsing pulse cannot occur in MR. It can only occur in AR due to rheumatic. In AR, what happens is that the systolic BP will be high, the diastolic BP will be low, so you will have a wide pulse pressure. Here you have highlighted that the pulse pressure is only 40 millimeter. So there is no congruity between your pulse and blood pressure. So at this particular point, if you have a physical examination, the examiner will ask you to go back and check the pulse. It's very, very important. You understand? So here, basically, the blood pressure indicates actually a low output status rather than a high output status. That is okay. That is one point. We are going to auscultation and whether we can see.
The lower limb, you have brought it out. 120/70, 50 is the pulse pressure. properly. Maybe the cup size which you used for upper limb probably was not right. Okay. So whenever you have a large volume collapsing pulse, you should have a wide pulse pressure. More than 40, definitely you should have a wide pulse pressure. Right? So 120 by 70, here you have got 50 pulse pressure. So that goes along with your collapsing pulse. So the take-home point here is whenever you have a large volume collapsing pulse, as sir rightly said, you should always suspect aortic regurgitation. So along with mitral regurgitation, you are also going to look for the murmur of aortic regurgitation. So 2 regurgitant lesions. We are expecting. Okay, go ahead. And
Jennifer, JVP of 8 centimeter. Is it normal or abnormal?
Abnormal, sir.
Hello?
Abnormal, sir.
Abnormal. What is abnormal? What is the cutoff for abnormal in an 11-year-old girl from the sternal angle?
5 centimeter.
5 will be little high. Maybe 3, more than 3 will be definitely abnormal. Okay, doesn't matter. Next slide. Anyway, it is high, 8 centimeter. Right.
Yes, go. Yes, very good.
Weight of the child is 22 kg against an expected of 36 kg, which is less than 3rd percentile. Height of the child is 125 centimeter against an expected height of 143 centimeter, less than 3rd percentile. Stunting is present. BMI is 14, between 5th and 10th percentile. Thickness is present. SMR grading stage 2, and arm span 125 centimeter.
Excellent. Your previous slide, which had some mistakes, will be wiped by this excellent slide because you have brought out all the points beautifully. For 11-year-old child, I really appreciate you having taken the SMR. It is mandatory. And again, your BMI, you have classified the child as severe among thinness. Comes under thinness as per your class, as per your IAP classification. Very good. And you have classified it as stunting is there in the child. All your classifications you have rightly made out. Very good. And I was really thrilled by this arm span 125 centimeters. But you are justifiable in taking the arm span. Why did you take? You wanted to rule out?
Mitral prolapse, Marfan. Hemocystinuria.
Very good, excellent. This child had 2 regurgitant lesions, mitral regurgitation and probably aortic regurgitation. You wanted to rule out a Marfan syndrome also in this child, and you have taken the arm span. But the presenting manifestation of Marfan will not be fever and joint pain, but you have taken the arm span thinking in terms of, because there were 2 regurgitant lesions. Very good. Arm span is very good.
Important point, right.
Very good.
This is normal. Jennifer, this is normal. No, 125 is normal, right?
Yes,
go ahead.
Yes.
Head to foot examination, skull normal, no facial dysmorphism, eyes, ears normal, nose normal, mouth no dental caries, no tonsillar enlargement, no throat congestion, chest wall no deformity, extremities normal.
1 minute. Chest wall no deformity. What deformity you look for in this child? Don't tell me kyphoscoliosis. Don't tell me no kyphoscoliosis. What else you are looking for in this child? What type of chest deformity you are looking for, or chest finding you are looking for? This child is having chronic respiratory distress, has been having congestive cardiac failure, repeated attacks, and for the past 2 years. Anything else you look for? It's an older child. Harrison Zulkers you can always look for. It's more common in younger children, but you can look for. Okay, yes, go ahead. Extremities are normal. What do you mean by that?
Ma'am, the joints, ma'am, extreme.
No joint, no joint swelling. You will look. Okay, go ahead.
Large joints in the upper limb, no swelling, no redness. Lower limb, knee joint on both sides, no swelling, no redness, no joint-like tenderness. Small joints in the upper and the lower limbs are normal, and no deformities are present. No genuine lesion, osseous node, rash, petechiae, purpura, or any splinter hemorrhage. No subcutaneous nodule or erythema marginatum.
Where do you look for subcutaneous nodule, and what position you look for subcutaneous nodules? What are the places where you were looking for subcutaneous nodules? Does patient complain of subcutaneous nodules at any point of time? Have you seen a subcutaneous nodule?
No, ma'am.
Madurai, we have seen one board. All of you go and see in Madurai. Okay. Now have you seen? No. Okay. Subcutaneous nodules, where did you look for in the, if you're supposing you're going to look for, where did you look for in this child?
Extensor aspect near.
Okay. No, start from the occiput. Yes.
Back. Extensor aspect of the limbs.
Okay. Wrist. Okay. Extensor aspect of the wrist. Okay. Elbow. Okay. Then pinadi cholunga. Usually we tell them blessing position over the occiput, over the blades of the scapula, over the spine, all those places you will have to put. Are they painful or painless? They are painless. Very good. And what does presence of subcutaneous nodules indicates what? If you see it, you should know immediately what. What is the patient likely to have? Child is likely to have carditis. Definitely, child is likely to have carditis. But are they common? Very, very rare. What percentage probably?
1%.
Okay, good. So subcutaneous nodules are not common. When present, they always indicate underlying carditis. Okay, yes. Yes, go ahead. Yes.
Coming to systemic examination, CVS examination, inspection, chest wall symmetrical, no deformities, no kyphosis, scoliosis, increased precordial activity present. Trachea appears to be apical impulse visible at the left fifth intercostal space, the midclavicular line, visible pulsation seen over the suprasternal and supraclavicular region, no epigastric pulsation, sinus cord, dilated veins, elevated JVP of 8 centimeters.
Okay. Okay. Keep that slide. No. See, this is inspection, only inspection.
Okay.
You cannot say apical impulse is visible at left fifth intercostal space in the midclavicular line. So to avoid such a problem, what you can do is you can combine inspection and palpation. That is a better way and safer way in the examination.
Okay.
Then you are saying that
have you written the same point in the palpation also, fifth space?
In palpation also it was in fifth space, but outwards was pushed out.
So I think basically better not to locate the apex in the inspection, right? Yes. And elevated JVP need not come at the inspection. No, it is basically we have already covered the neck. Okay, go ahead. Yes. So you feel the inspection we will skip. We are interested in two things: palpation and auscultation.
Yes,
go forward.
Go ahead.
Palpation. All inspectory findings confirmed trachea in the midline, apical impulse felt at the left fifth intercostal space in the midclavicular line, hyperdynamic in nature, no parasternal sleeve, systolic thrill over the mitral area present, no palpable P2, no carotid thrill, epigastric pulsation not
felt. Okay, this slide is very, very important because this gives you an idea what to look for in the auscultation. So, according to you, is there cardiomegaly or not? Gopika, do you feel that there is cardiomegaly? Based on this finding, is there cardiomegaly or not? Yes or no?
Yes, sir.
Yes. Is it a mild cardiomegaly, moderate cardiomegaly, or marked cardiomegaly? Based on this finding. Is it mild, moderate, marked? It is in the fifth left intercostal space in the midclavicular line.
What is the normal location of the apical impulse in this 12-year-old girl? Usually it is in the, up to 4 years, it is in the fourth intercostal space. Beyond that, it is likely to be in the intercostal space, internal to midclavicular line. No? So it is just lateral to the midclavicular line. So this is mild or moderate or severe?
Mild cardiomegaly. So Radhika thinks that this is a mild cardiomegaly. Okay. So do you think that your assessment, physical assessment of Jennifer, is it surprising compared to the history and all?
Yes.
Do you find it surprising?
Yes, sir.
You find it really? I find it really surprising. I was expecting the apex to be somewhere in the anterior axillary line. But anyway, it's a very interesting finding.
But and here, we will ask you to go and verify the finding, and the examiner will walk with you and say, show the fifth space. Because it will definitely be in the sixth space, as sir said, maybe close to the anterior axillary line. You have shown, you are expecting 2 regurgitant lesions from your DP and from your history. So in such a case, for you to have in the fifth space indicates what? It indicates only a lateral shift. There is no downward shift. So it is only a right ventricular hypertrophy. And again, you are not substantiating your right ventricular hypertrophy. You are not having any parasternal heave. You are not having no palpable P2. So those two again, if you are having palpable P2, parasternal heave, it indicates right ventricular hypertrophy, pulmonary hypertension. You can think, but this child you are expecting in aortic regurgitation, mitral regurgitation, which ventricle you are expecting to enlarge?
Left ventricular.
Left ventricle produces a downward and outward shift. So fifth is only a lateral shift. So definitely we will ask you to go and verify. At that point of time, please verify properly and say it is in the sixth left intercostal space,
whatever.
in the anterior axillary line. Don't stick on to your statement fifth space, right, Jennifer? Whenever the examiner asks you to go and verify, it is usually you. Most of the times you are maybe wrong. Okay, so always you should correct it at that point of time. Okay.
Gopika,
Yes, sir.
Gopika, you are there, no?
Yes, sir.
There is a systolic thrill over the mitral area. What do you expect on auscultation? Or what is the lesion? What is the likely lesion? Simple, very simple question. There is no
Mitral regurgitations. Mitral regurgitations.
So it's a grade 4 systolic thrill over the mitral area. It must be MR. Is there any other cause, any other rare cause for systolic thrill over the mitral area? Apex. We call it as apex, no? Any other? Have rarely apical VSD. There can be a restrictive muscular apical VSD which can produce a thrill. But practically in an 11-year-old child, systolic thrill means the child is having significant mitral rigidity.
Okay.
No parasternal heave, no palpable P2, no epigastric pulsation. So which means that there is hardly no significant pH, right? So lot of findings you are getting. One perplexing finding is that the cardiomegaly is not what we expected. There is second point is that there is no moderate or severe pulmonary hypertension. And third is you are likely to find a loud apical pansystolic murmur, right? So this is why palpation is very crucial in cardiovascular examination. Now you go ahead to the auscultation.
But at present, for all practical purposes, we'll imagine the apical impulse being in the sixth space from what all you have presented. It is unlikely to be in the fifth space. Okay. Probably you have missed a fifth or sixth space because this child is a 12-year-old child with breast and all that. You wouldn't have probably been able to examine. That's what I am assuming. Okay, go ahead. Okay, next. Auscultation. Auscultation. Go to the auscultation. Yes. Jennifer, go to your auscultation. Next slide.
Auscultation, mitral area. S1 soft followed by a high-pitched soft flowing pansystolic murmur of grade 4 heard at the apex, best heard with the diaphragm of the stethoscope radiating to the axilla on the back with the murmur best heard in expiration. S2 engulfed with the murmur. No S3 diastolic murmurs.
Very good. Yes, tricuspid area, same.
Tricuspid area, S1
okay.
Present, same pansystolic murmur heard in decreased intensity.
Okay. 1 minute, this slide is important. Babu sir, edha kekuma andha edathula? Previous slide.
Previous slide, go to the previous slide.
Previous slide.
Okay. So what is the importance of the third orson? How will you decide about the severity of mitral regurgitation? What are the points for the severity of mitral regurgitation? In addition to routine pansystolic murmur, what are the other points to say that it is a severe MR?
Presence of S3 gallop.
Okay.
All gallop presence of third orson. One more point.
Yes.
Mid-diastolic severe regurgitation. There will be mid-diastolic
okay. Flow murmur of mitral diastolic murmur. Okay, right, good.
Point S1 soft. Why are you telling S1 is soft? That's very important. That indicates soft S1. Soft S1. Mitral stenosis S1 is loud.
Oh, first sound.
Loud odd sound. Loud S1. Loud. Whereas this why S1 is soft. Soft
valvulitis.
Valvulitis. You want to say cardiac? Or something else.
See, Jennifer, there are how many leaflets are there for mitral valve, Jennifer?
Sir?
How many leaflets are there for mitral valve?
Anterior and posterior.
Anterior and okay,
posterior.
PML and AML. They have to oppose each other to produce a S1. In MR, they never touch each other because there is a leak. So there is what you call as a opposition of the AML and PML is not good. So you get a very soft S1. Then you can always say that this could be a reactivation. Reactivation can produce a carditis, and carditis can produce a soft S1. So two reasons.
Yes.
But in a chronic MR, the most important reason, as Madam was suggesting, is the lack of apposition of the AML and the PML. Then you said another very interesting word. You're using very interesting words. S2 engulfed in with the murmur, like Ukraine engulfed in the war. So what is meant by S2 engulfed in the murmur? See, if the murmur engulfs the S2, then by definition it becomes a continuous murmur, because a murmur cannot go beyond S2. So what do you meant to us? Because of a very loud murmur and a long it's a pansystolic murmur, you could not appreciate the S2. That is what you said, right? At the mitral area. So it is safer not to comment on the S2 at the mitral area. You comment S2 only at the base of the heart, both aortic area as well as the pulmonary area, which we will see. Next slide.
Okay, one pepper question for you to make one easy question. What are some common causes of pansystolic murmur? 3 causes for pansystolic murmur, which you know of. Thinking that you're going to answer, definitely I'm asking easy question, Jennifer. Gopika, Radhika, anybody? If she doesn't know, yes, yes.
Mitral
Mitral
regurgitation, tricuspid regurgitation, and BSD.
Yes, okay. How can you differentiate between a tricuspid regurgitation murmur, pansystolic murmur due to MR and due to TR?
Side first left-sided murmur is interested in expression, and right-sided murmur interested in inspiration.
Very good. That's a very important finding. Okay, okay. Proceed. Very good. Yes, like the same murmur is heard in tricuspid area. Okay. See, Jennifer, now we are contradicting your own statement. There you said P2 is not palpable. There is no parasternal heave. But now on auscultation, you are able to hear a loud P2. Am I right? Yes? Okay, it may be the case also. It's on auscultation, loud P2 you are able to hear. Okay. Yes, yes.
Jennifer, when you comment on S2, you should say first S2 is heard with variable split, then comment on the P2. P2 should come later. You first comment whether the S2 as such is split or not, and then comment on the P2. So the ideal way would be a S2 variable split with a loud P2. That would be the correct way of approach. Okay. So which means that there is some degree of pulmonary hypertension, but not much, because most of the palpatory findings are not there for PAH. Okay. Go ahead.
Okay. Yes.
Yes, Jennifer.
Yes. Proceed.
First aortic area, soft PA2, early diastolic murmur of grade 2 set, and second aortic area, high frequency, soft blowing early diastolic recurrent murmur of grade 2 is heard with the bell of the stethoscope. At the end of expiration, western patient leaning forward.
Patient. Okay. Position.
Carotid normal, no fluid, auscultation over the back normal.
Jennifer, what is this first aortic area and what is the second aortic area? You tell me. Can you be a little louder?
Right, the second intercostal space.
What is that? What is meant by first aortic area and what is meant by second aortic area? Suppose you were to teach a third year MBBS student, how will you teach them?
Second aortic area is right side second intercostal space.
No.
Second area is in the left third space. This is the left third space.
Left third space.
Second area is the left third space. Okay, Jennifer. Okay, yes.
So did you use the bell? Another very interesting point is that you heard a high frequency soft blowing. Jennifer.
Early diastolic.
Jennifer, can you hear me?
Yes.
Yeah, Jennifer, be very calm. See, there's a practical problem here. You have a high frequency soft blowing early diastolic decrescendo. It's a very long adjective like murmur of grade 2 is heard with the bell of the stethoscope, which I find very perplexing. Madam is also perplexed. Everybody is perplexed because we all feel that this murmur is a high-pitched murmur. High-pitched murmur cannot be heard best with the bell. It is with the diaphragm. Fundamentals of cardiology. So I think this is a very, I mean, honestly speaking, in the examination, this is going to cost any candidate very dangerous. It has to be with the diaphragm, right? Bell is used for low pitch sound. Be very, very careful, right?
Okay.
Because you are typically describing an AR murmur. Everybody can know that it's an AR murmur, and you are using the bell. That is not correct.
Okay.
Okay. Right.
Okay. Proceed. Okay. Other systems. Next slide.
Respiratory system, child tachypneic, bilateral normal vesicular breath sounds, no added sounds, bilateral basal crepitation.
Basal crepitation indicates child is having probably
pulmonary edema.
Edema. Okay. Yes. Left ventricular failure. Yes. Next slide. Next system.
Abdomen. No, abdomen not distended, soft, tender in the right hypochondrium, liver palpable 3 cm under right costa margin.
Okay. Okay. So child is having a soft, tender hepatomegaly. Okay. Yes. Next slide. Next slide.
Central nervous system, higher mental functions normal, no focal neurological deficit, no involuntary movements, no milkmaid sign, pronatal sign, or spooning or dotting tongue present.
Okay. There is no chorea according to you also. Okay. Okay. Yes. Next slide.
Positive clinical findings. Child was dyspneic addressed, elevated JVP was present, large volume collapsing pulse with wide pulse pressure, positive sign, hyperdynamic apical impulse shifted outwards.
Upward and downward. You'll have to modify here. Outward and downward. Systolic thrill over the mitral area. Yes.
No parasternal heave. Pansystolic murmur of grade 4 in the mitral area, which is radiating to axilla. Loud P2 and systolic murmur of grade 2 in the pulmonary area.
Okay.
Tender hepatomegaly, no
Okay. Next slide. Can we go to the next slide, sir? Can she give a diagnosis, sir?
Yeah.
Yes. Yes, you tell your diagnosis.
Jennifer, you are not audible, Pa.
Okay, you tell the yes.
Tell the diagnosis, Jennifer. Radhia.
Yes.
Sir, am I audible,
the
sir?
diagnosis,
Yes, audible now. Abhi vachiko konja nera 2 minutes abhi.
Am I audible, ma'am?
Yes.
You are audible.
Diagnosis: a case of acquired heart disease of probably of rheumatic etiology, probable valve involved or mitral and aortic valve with mitral and aortic regurgitation, child in congestive cardiac failure and pulmonary hypertension, child in sinus rhythm with no infective endocarditis with ongoing rheumatic reactivation, with the normal development and immunization status with thinness.
Okay, complete diagnosis you have given, and you substantiate each finding. Acquired heart disease. Yes. Why you say acquired heart disease? The onset of the illness was around 10 years. It started only at 10 years. Okay. Why do you say rheumatic etiology? Child had fever.
Criteria.
Child had fever.
Criteria. Already the child is a known case with now satisfying the criteria for rheumatic fever.
Okay. So you wanted child is having fever with joint pain and okay. So that's why you thought it was rheumatic. What is the finding for mitral regurgitation you had?
Mitral regurgitation, murmur.
Start with murmur. You had a large volume. You had a high volume size. Yes.
Collapsing.
High pulse pressure you had. Yes. Then
systolic thrill over the mitral area.
Yeah. Yes. Then you had.
On auscultation, there was grade 4
pansystolic murmur you heard. And you heard for aortic regurgitation. What are the features for congestive cardiac failure you had in this child?
With the elevated JVP, child was dyspneic with the elevated JVP.
And
on inspection, there were Yeah.
Tachycardia was there.
Tachycardia was there.
Tachypnea was there.
Tachycardia was there.
And what is the most
respiratory
sign of congestive cardiac failure in children? The most consistent clinical sign of CCF in children, whatever be the age group. Can you rely on JVP in young children, young infants? Can you rely on JVP in infants?
No.
You cannot rely on JVP in infants because the neck is very short and you may not be able to do the maneuver. Okay. So, what is the most consistent clinical sign of congestive cardiac failure in children? Tachycardia, tachypnea can also be present in pneumonias. So, any other condition, even in fever, you can have tachycardia and tachypnea. So, what is the most consistent sign of congestive cardiac failure in children? Usually, we are very worried about. We always look for it. Tender and soft hepatomegaly is a very consistent sign in all children with congestive cardiac failure, right? What is the evidence of pulmonary hypertension you saw in this child? Your P2 was loud, right? Jennifer? Gopika, did you, that was a sign of pulmonary hypertension. Sinus rhythm, yes, right? Okay, normal development with thinness. Can we go to the next slide, sir?
Yeah, 1 minute. Jennifer, can you hear me?
No, sir, she is not able to.
No problem.
Okay, and then Gopika.
Continue, sir. We have 25 minutes more. Yes.
Okay. Gopika, last question from my side. See, this MR and AR, based on Jennifer's physical findings, do you think is it a significant MR or a mild MR? Is it a significant AR or a mild AR? What do you feel from her findings?
Sir, from inspection, there is hyperdynamic impulse. It favors to the MR. But it can be a MR.
No. I want a specific answer from Jennifer's finding. Is the MR mild, moderate, or severe? Is AR mild, moderate, severe? Honest, I mean, with reasonable margin. What do you feel?
MR not severe, sir.
Not severe. So it is not severe, according to you. What about AR?
AR also not severe, sir.
Okay.
No shifting of the impulse was there.
Which do you think is dominating? Overall, it is very
dominating one is mitral.
You think it is a mitral regurgitation which is dominating? Okay, correct. So you feel that both MR and AR are not very severe, but among the two, MR seems to be dominating. I agree with you. Okay.
Yes, sir.
Right.
Okay. Next. That was the last slide, Jennifer. Okay, her slides are over, sir. Now, shall we, sir? We have 20 minutes. I think shall we complete the investigations and treatments, sir?
I think we will go to the continue with the case discussion because that will be more useful.
Ask a question to the presenter.
Yes, I think.
Jennifer, can you talk now?
The presenter. Can I ask a question to the presenter?
You completed a case sheet, Jennifer? Okay. Sir, what are the investigations you are going to proceed now, Radhika? Now the diagnosis is over. Now, Jennifer said there is evidence of reactivation. How will you confirm your reactivation or activity in this disease? What are the investigations you are going to do? Radhika, Gopika?
Yes, sir. Blood investigations like ESR, CRP, ASO titer, and chest X-ray, ECG, echocardiography to confirm the carditis.
No. For carditis, you want CBC, ESR. Among the two, which do you prefer? ESR value more than how much you take it as positivity? You want to take it
more than
30 or 60? You want to take it as positivity for country? ESR
more than
ESR more than
30 millimeters.
Yeah, ESR more than 30 is enough for us. Okay.
More than 30 in a patient who are living in moderate high risk area, we have to consider as a positive ESR, right?
CRP
more than 30 is significant, right?
Yes. CRP more than how much we take is significant?
3. More than 3.
Okay, 3 per deciliter. 3 milligrams per deciliter or per liter?
Milligrams per deciliter.
Per deciliter. Okay, ESR more than 30 and 3. Among these two investigations, which do you prefer, ESR or CRP?
CRP is more preferred than ESR, ma'am.
Patient, ESR or CRP, which do you prefer, Gopika? You always yes.
Ma'am, for the diagnosis, I will prefer CRP because it is not influenced by any anemia or congestive cardiac failure. Once treatment started, I will seek for ESR to seek for the improvement or decrease in inflammation.
Very good. So you will rely on CRP more than the ESR because it is not affected by congestive cardiac failure or by anemia. Excellent. ESR, CRP. Then what else you need? What are the other investigations you are going to do this time? ESR, CRP, then chest X-ray. Chest X-ray, what are you going to look for? Chest X-ray, what are you going to look for? In this time with AR and
cardiomegaly.
Massive cardiomegaly is likely to be there. Okay, is it important for you to know whether it's massive cardiomegaly or mild cardiomegaly or no cardiomegaly?
Yes, ma'am, it is important to look for cardiomegaly.
Yes, why? Supposing carditis with mild cardiomegaly.
So that we can yes, ma'am. So that we can classify into mild, moderate, severe, and we can conclude to our treatment.
Okay, steroids are given only in moderate cardiomegaly and in severe cardiomegaly with carditis. Okay, yes. So you need to know that. What are the ECG findings you are going to look for in this child? If the child is having carditis, what is the type of interval? Yes, ECG finding. What are you looking for? You are looking for prolongation
interval
or prolongation of the QTC interval. What one thing about carditis in rheumatic fever? What is the type of carditis? You have endocarditis, you have myocarditis, or you have pericarditis in rheumatic fever. Which
Pancarditis in rheumatic.
So all three are involved. Pancarditis, but mandatory what should be there? Pericarditis, endocarditis is mandatory. Endocarditis is mandatory. How do you make out endocarditis clinically?
Murmur, by the evidence of murmur.
Endocarditis indicates valvulitis. Valvulitis, you should always look for the murmurs. What are the types of murmur you look for in valvulitis? 3 types of murmur. What are the murmurs you look for?
Cadicum's murmur, pan-systolic murmur, and the mitral regurgitation.
Very good. Excellent.
Also, and also midday murmur.
Okay, all the 3: Seagull murmur, Cadicum's murmur, or your EDM, early diastole. These are evidence. What will be the evidence for pericarditis you will look for in a child? Pericarditis evidence enna paapeenga? Enna rub paapeenga. Appo myocarditis enna evidence child?
Cardiomegaly, CCF.
Cardiomegaly, CCF. All these are evidence of myocarditis. Excellent. So you have now done a ESR, CRP, X-ray chest in this type, and you have already done a ECG. Now, what do you mean by subclinical carditis, Gopika?
Subclinical carditis, even though we can't auscultate any murmur, we will find some findings.
Echocarditis. That is called a subclinical carditis. You are not able to make out anything clinically. What is the importance of subclinical carditis?
According to modified Jones criteria, subclinical carditis is also a major criteria.
Excellent. This is what is expected from you. Okay. When do we do not follow Jones criteria very strictly? 3 conditions where we will not follow Jones criteria very strictly. Radhika? Nobody for me, no anybody.
Even if the first presentation is indolent carditis or presented with a chorea, or in case of recurrent rheumatic carditis, we will not follow the strict Jones criteria.
Very good, excellent. All these are three conditions where we will not follow Jones criteria strictly. Okay. Now we have done. You want to talk about the echo findings, or we leave it to the radiologist, cardiologist?
Echo findings.
We leave it to the cardiologist, sir. We leave it to Zulfikar, sir. Or you want to talk about the echo findings too and get into more trouble? No.
Ma'am, echo findings we are expecting in MR and AR is at least we have to look for the jet in 2 views, and the length of the MR and AR will be more than 3 meters per second. And
okay, so you know the echo findings. Okay. So subclinical carditis, echo finding itself is enough for you to make a diagnosis of rheumatic carditis. Okay. What are the investigations you want? Activity ku idella pannenga. Where any important investigation, evidence for streptococcal infection, you need some investigation.
Throat culture.
You require a presence of throat. How throat culture? Or nowadays we are not doing throat culture that commonly, especially in Chennai. No. What else we are doing? We are doing a throat culture. Rapid test we are doing. We are doing rapid streptozyme test for rapid test for streptococcal antigen. We are doing for evidence of gas. Gas na group A beta hemolytic streptococci. We are doing a throat rapid test. What are the investigation you want to do? Any other investigation?
Anti-double-stranded DNAs and anti-hyaluronidase.
We are not all doing, so we need not bother much about it. Okay, you have evidence for streptococcal infection. You have criteria for carditis. You have you are now thinking in terms of active rheumatic carditis. This child, how will you classify this carditis? As carditis with
severe carditis, ma'am.
Okay, severe. Your class carditis with cardiomegaly severe. Severe carditis, carditis with cardiomegaly severe. Okay. Now, sir, anything you want to ask, sir? Zulfikar, sir? Babu, sir?
No problem. You have completed everything, man.
Yes, sir. Sir, 10 minutes we have.
Can I ask you a question, madam, to the presenters?
Go for the treatment. It's okay. Okay.
What is the importance of combining all the three antibodies together? Why you want to?
High, sir. When combining all three parameters, ASO, anti-DNase, B, and anti-hyaluronidase, 95% specificity, sir.
What about the rheumatic urea? Rheumatic urea, what is the importance of combining all the three antibodies together? What is the stage at which all the antibodies are the highest titer? The rheumatic fever patient with the classical manifestation, the titers of all the antibodies are at the peak. But in this case of rheumatic urea, this is a late manifestation. Sometimes one of the antibody titers may be alone positive. That can be taken as evidence for previous rheumatic fever, or a previous streptococcal infection. So rheumatic urea is better to combine antibodies against all the three antigens. Right? That increases sensitivity to almost 95 to 100%. When you do an antibody titer for one particular antigen, it's about 80%. That is the ASO. When you combine all the together, you can increase the sensitivity. That is for antibody titers are concerned. Right? What is streptozyme test? Is it being used? Why it is not being used? Streptozyme test.
Streptozyme test is not currently used, sir.
Okay. Why it is not being used? It's not standardized and also not quite repeatable. So it's not being followed. Right?
ASO remains positive for how many months?
1 month.
6 months.
Yeah,
6 months.
So though it is increased in case of rheumatic fever, we don't take it for treatment purposes. Positivity is streptococcal infection, that's all. Because it remains positive up to 6 months. So you can't use that for assessing your disease activity. When you start giving drugs, you cannot do a repeat ASO and check whether your drug is acting or not. Okay. So we always follow up, for follow-up investigations, we always use ESR or CRP, preferably a CRP. Okay. Yes. Now this child. Yes, sir.
ASO titers won't be positive. How much is clinically significant? ASO titer is found to be positive. And how much importance you want to give for a particular laboratory finding. You have to correlate clinically. So you try to apply the modified Jones criteria. If it is fitting and is elevated ASO titer, then only you have to give importance to the ASO titer. Otherwise, you just neglect. Don't put the patient under penicillin prophylaxis. Okay. That is another important critical point.
What is the treatment you would like to give for this child with active carditis, with severe cardiomegaly? What treatment you would like to give?
With severe cardiomegaly, initially bed rest, ma'am.
Okay.
Initially bed rest, oxygen if needed, NAPP ventilation. Next part is about nutrition, no added salt, and if there are any associated GRD or other symptoms, we have to treat that also. And next, anti-failures should be started, ma'am. After anti-failures, we have to start with prednisolone. If it is severe carditis, we have to start with prednisolone 2 mg per kg for 3 weeks, then taper to 1 mg per kg next 3 weeks, and every 3 days 5 mg tablet is reduced. And during this tapering time, we will introduce aspirin 75 mg per kg per day in 4 divided doses, 3 weeks, and half the dose for 3 to 4 weeks.
Great, excellent. Very good. You did a good job. Now, what are the side? When you have started giving steroids for 6 weeks, what are the side effects of steroids you are going to monitor in any child who is going to be on long-term steroids? Common side effects which we see in children.
Growth retardation, osteoporosis, glaucoma, cataract.
Yes.
Gastritis, hypertension.
Okay.
Gastritis, hypertension, Cushing's triad, and sometimes presented with the long-term cataract and diabetic mellitus.
What
are the side effects of salicylate? You are giving salicylate in larger doses, 75 milligram per kg per day. What are the common side effects of salicylate, or what is meant by salicylate?
For aspirin, what are the common side effects? Yes.
Salicylate toxicity, we have to monitor for tinnitus or vertigo.
Vestibular toxin is very important. And also hyperventilation. Sometimes it is associated with metabolic acidosis. Patient may have hyperventilation also. These are the important side effects with the aspirin therapy.
Okay. Yes. Okay. Sir, Zulfikar sir, congestive cardiac failure management. Sir?
Sir has muted himself.
Okay, sir. Shall we proceed?
You are not audible, sir. Sorry.
Yes, sir. Yes, I muted himself.
Am I audible now?
Yes.
Yes, sir.
Radhika, you said so many. You two people said so many adverse effects of steroids and rheumatic fever. But which do you think are more important? You said all those so many things, but minimum things which we clinician look for in our wards. Blood pressure. We should always take the blood pressure because blood pressure can be elevated. Then potassium. Once in a while, you should do a potassium because there can be hypokalemia. These are the two things I think practically you should look for. The other thing like your cataract and all that, I mean, usually not there. That is one point. Then another mistake you made was that, Jennifer or everybody made mistake was that after this ESR CRP business, you suddenly went over to X-ray and ECG without mentioning ASO. Without mentioning ASO, you cannot go forward with the chest X-ray and ECG. That's very, very important. ASO, and never say all these three things. Start with a simple ASO. That is the most reliable, most commonly used thing. Only after ASO, suppose you suspect rheumatic fever, but still ASO is negative, as sir was saying, you can combine ASO with the anti-DNA. Never start with anti-DNSB in the examination. Be very, very careful. It might irritate the examiner, right? And another practical thing is that even now, I am not very comfortable with your blood pressure recording. So if you have the patient with you in your ward, I think you should go back and find out.
Sir, we will check and once I will do on the clinical examination.
Yes, sir.
Yes, okay.
That's all.
The CCF management, sir, you would like to add on something, sir?
No, yeah. One point regarding heart failure in rheumatic carditis is that better to avoid digoxin. Digoxin is useful in acute rheumatic carditis. You basically use a diuretic and an ACE inhibitor and bank on steroids because ultimately it is a steroid which produces dramatic relief, and combine that with a diuretic and an ACE inhibitor. No, digoxin is not
It's not contraindicated, but it is not indicated. That would be my
Would
viewpoint.
you like to use Radhika? So I mentioned ACE inhibitors. Which ACE inhibitors you would like to use? You want to use captopril or you are using enalapril?
Enalapril.
Why are we using enalapril, Jennifer? Why are we not using captopril?
Jennifer, yes, you want to use?
Because captopril is not available. Captopril is not available in India. Gopika, captopril is not available in India. The only enalapril, lisinopril, all those things are available. Captopril is not available. So that is why you don't use. Because in a small baby, captopril is a very good drug. We can titrate. But enalapril, what is the dose of enalapril? Who is the on my right side? Gopika or Radhika? Point?
0.5 to maximum 2 mg per kg.
What? You are talking about enalapril? You are talking about enalapril in a child. How old? What is the weight of this child? 18 kilogram, no?
20.
How much? Okay.
0.05 to 0.4 mg per kg, sir.
Jennifer, what is the dose of enalapril per kg per dose in a child? 0.05
to 0.4 mg per kg
per dose.
Sir,
How many doses?
0.05 to 0.4
Milligram per kg per dose. How many doses? Gopika and Radhika can help her. What does Gopika feel?
We'll tell them the answers are 5 to 6 minutes more.
Yeah. See, I mean, Jennifer, the dose of enalapril in pediatric practice is maximum 0.1 milligram per kg per dose. Maximum of 3 doses. Usually we give it twice daily. So you cannot talk about 0.3 to 0.5 milligram per kg enalapril and get away with it. No, I'm so sorry. I mean, to have caused you some trouble, but it is very dangerous statement. 0.1. It is actually 0.08. So we are making it as a 0.1 milligram per kg per dose, maximum of 3 doses. So that you have to be very, very, it's a very powerful drug.
Okay. Now we manage the congestive cardiac failure. You have started the child on steroids and you have given the appropriate dose of steroids. You are monitoring for the side effects of the, any other drug you would like to continue for this drug for preventing recurrence?
Second, penicillin prophylaxis.
You're going to give penicillin prophylaxis. This child has got carditis now, that is definite. This child, does it have established heart disease or not? Is it important for you to know now? Yes, because you will decide on the duration of prophylaxis accordingly. Okay, first you tell me whether this child has got established heart disease or only carditis child is having. Child is having established heart disease, you feel. What points favor presence of established heart disease?
What is the importance of thrill?
Systolic thrill was there for this child. That indicates this child has been having this disease for quite. Okay, this child has got carditis with established heart disease. Now, what prophylaxis for how long you are going to give? What drug you are going to give? You are going to give oral penicillin or you are going to give parenteral penicillin? Which do you prefer?
Oral penicillin. Oral penicillin 250 mg BD. In this case, we are giving for lifelong prophylaxis.
For years or up to lifelong? You prefer lifelong. Okay, that's the. Why you don't like injection penicillin? Injection benzathine penicillin? Compliance is better in penicillin or injection benzathine penicillin?
Oral penicillin. Compliance is.
Okay. What is the problem with injection benzathine penicillin you feel, Radhika? You want to prefer give only oral penicillin. What is the problem? Available. It is free. It is available. Benzathine penicillin is available. That's what is your problem in giving it?
The most dangerous problem. Why you are afraid of giving injection benzathine penicillin?
Anaphylaxis.
And anaphylaxis, once this time you have given benzathine penicillin, you have done a test, you have given the drug. After how many weeks child is going to come back to you again? 3 weeks or 4 weeks? Okay, 3 weeks. 4 weeks come back. At that point of time, again, will you have to give a test dose again, or no need? The previous time you have given a test dose, no need for the next time.
Every time we have to discuss.
Chances of getting anaphylaxis during an injection of benzothane-penicillin. For every 1 in 10,000 cases, you are likely to get an anaphylactic reaction. Now, even if you haven't known how to manage carditis, I will not be worried. How will you manage a child with anaphylactic shock? All of you should mandatorily know. What will you give immediately if a child develops anaphylactic shock?
Adrenaline injection, adrenaline IM, ma'am, IM injection, 0.01 mg per kg, 1,000 dilution.
1,000 IM. The next drug which you will give is, child has developed anaphylaxis, you have given one dose of injection adrenaline. What is the next drug you are going to give?
Injection Avil and hydrocortisone.
Don't fall into my trap, it is again injection adrenaline. Are there 2 doses? How many ever times you ask, the drug of choice for anaphylactic shock is injection adrenaline, injection adrenaline, injection adrenaline, right? And you should always have it in your hand, because it can produce instantaneous death if you don't manage the child immediately. Okay, hydrocortisone, Avil, they play no role in a case with anaphylactic shock. Is adrenaline associated with any side effect in children? Absolutely no side effect, because in adults you'll have to be worried about angina, getting chest pain and all that. Children's heart have a good reserve, so don't worry about adrenaline in children. Okay, so drug of choice for anaphylactic shock due to benzothane-penicillin is adrenaline. Now you wanted to give once in 3 weeks or 4 weeks benzothane-penicillin, which is what do the recent advances say? 4 weeks or 3 weeks is better?
3 weeks. 3 weeks, ma'am.
You want to give it one. Supposing a child has developed allergic to penicillin, what are the other drugs you want to give?
Erythromycin, erythromycin.
Okay, you want to give erythromycin.
BD.
You have completed penicillin also. Your child is also continuing. Then this giving penicillin prophylaxis, which is the degree of prophylaxis? It's a primary prophylaxis you are doing, or secondary prophylaxis, or what is the type of prophylaxis we call this as? After the child has developed heart disease and all that. Okay, it is a secondary prophylaxis which we are giving. Okay, what do you mean by primordial prophylaxis? Is
Vaccination against group A.
Is hygiene to prevent the attack of group A streptococcal pharyngitis by improving the hygiene, avoiding overventilation and avoiding overcrowding.
So you feel prevention is better than cure, but unfortunately we do not have that vaccine. Improving the socioeconomic status and vaccination will probably improve the child. That is what you feel. Okay, very good. Thank you. That's all. My questions are over. And I feel that all of you did a good job. You could have concentrated a little more, but you did an excellent job. Presenting and answering the questions of a super specialist is not simple, Jennifer, Gopika, and Radhika. They were asking questions which are very difficult for all of us, but basics, we should never make any mistakes. For example, one thing I was very worried about are the 6th intercostal space. ARMR, when both are present, it cannot be in the 5th space, which will have to. So you'll have to be very careful about your clinical examination. But all 3 of you did a very good job, and you should really thank your mentor, Dr. Babu sir, for having done this. Thank you. I thank you sir and Babu sir for having traveled with me for the last 2 hours. Thank you, sir.
Thank you.
Thank you.
Thank you.
Yeah,
thank you.
Thank you, sir. And I request Dr. Zulfikar Agaman sir, any concluding remarks, sir?
Yeah, I think one point I observed was that.
Sir, the camera, make it down.
Okay, because my computer, there's a problem with the computer. I'm using my phone. Now you can see me.
Yeah, please, sir.
Yeah, the point the postgraduate should remember is that all 3 of you are presenting a little faster than what we expected. You have to be a little more slow. We need not be as slow as ourselves, but you have to be slow so that the examiner catches all your finer points. That is very, very important. And secondly, this correlation between, the BP and the pulse correlation, you should always cross-check. So whenever you take the BP, you recheck the BP again. That will be very important. And this apex beat, BP, they are all reproducible finding. So you cannot cheat the examiner with this reproducible finding. For example, you can say I am hearing a grade 2 by 6 murmur, but the examiner may feel, okay, maybe they are very young and they can hear. But reproducible finding, you have to be very, very careful, especially BP, pulse, rate, all those things. And weight, and of course in pediatrics, nutrition, etc., etc. So I think otherwise, I think the history, all these things were very good. And even you are answering all these questions to madam, you have to be a little more slow generally, so that the examiners, it can sink into the examiner. That's all I want to tell you as an advice.
Probably trained, sir, because the whole questioning in the examination will have to be complete by 15 to 20 minutes, sir.
That's the problem.
It's only 15 minutes. So they'll have to be fast. And in fact, I that because if they are very slow, then we can't ask too many questions in the examination. 15 minutes, maximum answers we'll have to get from them, sir.
Okay.
Really, okay.
The examiner also should be fast, I think.
Fast and have to be ready all the time, sir. 28 candidates in one day, we'll have to rush through, sir. No other go for us, sir.
Okay, thank you, madam. And I request judges' comments, please. Dr. Srinivasan, sir. Dr. Srinivasan, sir. Yeah.
Yes, I'm there, but yeah, I think clinical examination, there were a lot of discrepancies. I think they have to work hard on clinical examination. That's my sincere advice. Okay, I'm not harsh in my comments, but from the history and as well as findings, there were discrepancies. That's what I felt should not be there. Thank you.
Yeah, Dr. Ramesh, sir.
Yes, sir. All the exam points have been discussed. I only want to emphasize that the exam going students should be able to differentiate between carditis in rheumatic fever and established rheumatic heart disease. Carditis in established heart disease as well as reactivation of rheumatic fever. This they should be able to clinically differentiate as well as with the investigation. As I rightly pointed out, ASO and CRP should have also been discussed in this discussion. Thank you, sir.
Thank you, sir. And now I request Dr. Ramachandra Bhavan. Unmute, madam. Unmute.
Nothing much to add. Whenever Lakshmi is there's nothing short of fireworks. And I mean, to stand up to Lakshmi's questioning, I think requires a separate glass of boost or something. And Zulfikar sir is his usual calm self and just bringing up, very relevant questions at regular intervals. And of course, I think Babu sir had done a good job in motivating the PGs. They stood up to all those questioning.
Yes, correct.
Barrage of questions from all of you. My God, they stood up to all that. And I think towards the end, they did extremely well, sir. In between, I think they lost. They were a little demoralized, especially the clinical part when they had missed out a few findings. Initially, they did well, of course. And towards the end, they really...
All the management answers they did well. Anyway.
They know what questions we will ask and they were answering the appropriate, but they didn't know what questions you will ask.
And whatever said and done, finally it's your clinical findings which is going to see you through. And if you whatever is there, you just have to say it. That's all. Even if you cannot explain, sir, I'm not able to explain, but this is what I'm finding. As sir says, the reproducibility, those things are cross-checked by the examiner and they also find the same findings, then you are safe. So on the whole, absolutely complete examination. I think rheumatic, they don't have to go back and read. Fantastic job by the examiners and PGs. All credit to Babu Kandakumar also for.
Thank you.
Thank you.
Thank you, Rama. Thank you, Ramesh sir. Thank you, Rajendra.
Thank you, Dr. Babu Kandakumar. Dr. Babu Kandakumar, any comments, please?
No comments, sir. Thanks all the judges, chairperson, and moderator for spending your valuable time. And you gave a very good information as well as knowledge to our PGs. Thank you, sir. Thank you.
Yeah,
Thank you, sir.
Dr. Annamalai Vijayaraghavan, sir. Sorry, it's not there. Okay. On behalf of IAP TNSC, I thank today's chairperson, Dr. Zulfikar Ahmed, and I think sir is attending his third under postgraduate presentation. Correct. Really, we are postgraduates. They are really benefited, sir, and and on behalf of IAP TNSC, really thank you. And our Dr. Srinivasan sir salute adik solrar. Salute sir.
Yes. Avarku salute.
Yeah. And I thank Dr. Lakshmi Velmurugan madam. And usually she's having a lot of where we are case discussion. She's having so much of enthusiasm and for case discussion, and on behalf of IAP TNSC, I thank Dr. Lakshmi madam, and I thank Dr. Babu Kantakumar, and I thank all the postgraduates. They done a very nice presentation, and I thank today's judges, Dr. Srinivasan, Dr. Ramesh sir, and Dr. Rama Chandramohan madam, and I think on behalf of IAP TNSC, I thank one and all for this wonderful opportunity, and thank one and all. Thank you very much.
Thank you, Srinivasan.
Thank you.